Good evening, everybody. On behalf of Chennai,
Please start.
Yeah. So, good evening, everybody. On behalf of Chennai Menopause Society, I would like to welcome you all for our CME on Menopause Way Forward. So, to start with, I would like to invite our President of Chennai Menopause Society, Dr. Shanti Gunasingh Madam, to address the gathering and give away the welcome address.
Okay,
Madam.
Fine.
Yeah, okay.
Good evening to one and all. It is indeed my pleasure to welcome all of you all to our webinar, Menopause webinar. And this is and we are also releasing our 21st edition of MUDL, Menopause Associated Disorders Awareness Letter. But on this occasion, we are really very saddened by the plane accident which has happened in Ahmedabad. We are really very upset about that, and we place on record our deepest condolences. And Dr. Neeta Mishra, I have great pleasure in welcoming her, but we feel bad that in this catastrophic condition, we have really invited her. She is the chairperson of Digital Awareness Committee Education, who is doing a lot of good activities. And we have Professor Sarla Gopalan, retired director PGI, and doyen, an OG doyen, one of the doyens of OG, whom we really look up to. And we are indeed happy to have Madam as guest of honor. We also welcome all the chairpersons, Dr. Premlata, Vice President, Chennai Menopause Society, Dr. Dhanlakshmi, who is our vibrant treasurer, and Dr. Mohana Pramila, our active CMS member, and all the speakers who have really taken time off to be amongst us and enlighten us. And we know menopause is indeed a multidisciplinary approach is what is really needed. And hence we have people from other departments like Dr. Muthukumaran Jayapal, endocrinologist, Dr. Sarveshwari, our dermatologist. Then we have our sleep specialist, Dr. Ramakrishnan, our orthopedician, Dr. Sendil Kamalasekaran, our physician, Dr. Swati, and psychologist, Dr. Napaya, then Dr. Sita Lakshmi, our urogynecologist, Dr. Jayashree Natarajan, our oncologist, and of course our own faculty, Dr. Deepa Tangamani. So it's indeed my pleasure to welcome all of you all. And this, the convener for this is Dr. Jayashree Gajaraj, founder president of Chennai Menopause Society, and Mala has been actively formulating the whole webinar. So I welcome, and of course I'm very happy to have all the delegates who have extended their support to us, and a happy academic enlightenment. Welcome one and all.
So, thank you so much, Madam Sahiti. So, we start with our Tamil Thai Vaithu with a traditional song. பிறந்து எந்த செயல் மறந்து வாழ்ந்ததுமே வாழ்ந்ததுமே வாழ்ந்ததுமே. Yeah, may I request our secretary of Chennai Menopause Society, Dr. Meera Raghavan, to say the menopause prayer, please.
Thank you, dear. We pray to God to give us the grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind, and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midwife and menopausal women, and inspire us to give this gift of hope to others.
Thank you so much, Dr. Meera Raghavan. Yeah.
Thank you. Dr. Neeta Mishra would like to speak before the start of the program.
I think we will go ahead with
Ahead
Dr.
with the order.
After that, we can do the lighting part.
Yeah.
Huh?
Yes.
Yeah. Can you just put a CV, ma?
Yes. Sahiti?
Yeah. Yeah. I welcome Dr. Neeta Mishra, who's really been kind enough to join even in this crisis, a member of Ahmedabad Menopause Society, Digital Committee, Education Committee Chairperson, and President of Ahmedabad Menopause Society 19 to 21. And she has a lot of publication in PubMed index journals, awarded Wonder Woman Award by Foxy in 2019, renowned cosmetic gynecologist and member of CFUW. Dr. Neeta Mishra, please.
Thank you, doctors, for giving me this opportunity. Today, I cannot speak for a longer or cannot sit in the webinar for a longer period of time. Yes, there is a in our own city. There is a plane crash, and I think I have to do something for my colleagues and my whosoever my patient. And so I'll speak about the menopause. So once each and every woman should understand that menopause is not the end of your life. You should really rethink of your life. Konaki is the Japanese word. So konaking is means reliving. I mean, every woman should think that it's not a stoppage. You should start reliving your life. And according to me, the younger woman is the gift of nature, and the once you age is the gift of art. So it depends how artistic you are and how you define your life in the future. I'm doing the cosmetic gynecology, and whenever the patients comes for the GSM, especially I'm treating the GSM. GSM is a genitourinary syndrome of menopause. It is of VVA, that is vulvovaginal atrophy, and the LUTS, all because of the ethinyl estradiol deficiency, or you can say the estrogen deficiency as you age. And we do with the if the patient is having, especially I do the treatment for the functional problems like the urinary incontinence. If the patient is having mild incontinence and have 100% be treated with the radio frequency device, it is an energy-based device which I am using. And there are so many other energy-based devices are available in the market, and one has to understand how it works and how whether to buy and when to buy. These are the different what called the stages. And for the stress urinary incontinence, there is a Amsela chair, Tesla chair that gives the almost the Kegel exercises, 11,200 exercises in 20 minutes. In an OPD procedure, patient can sit for about 20 minutes on that chair, and she'll be relieved. She'll be relieved from her incontinence. So one should start living the life after the menopause or during the menopause. Perimenopause is, we know that is 42 years to 52 years. It's a perimenopausal period, premenopause and the postmenopause and the menopausal age. And like I am also 65, but I'm always busy with my work. Right now I'm the Digital Education Committee Chair. I have organized one dance competition, and I am really I'm very happy to announce that most of the winners are from the south. You guys are doing the best. You are the best dancers, and it is a very brainstorming, and it is the I mean what you call the
I think she's lost her connection.
Yeah, maybe.
She's lost the
Just,
connection.
just call her up, no?
Come, madam.
She's come back.
Yes, madam.
Hello?
She is on mute, madam.
Joining?
Dr. Neeta Mishra's speaker on mute.
Madam, you have to unmute Dr. Neeta.
Yeah, she's there.
I'm leaving
Madam,
now.
you have to unmute.
Is it okay?
Oh, okay.
Hello, Dr. Mala. Shall I
Yeah, madam.
leave or shall I
Yes,
talk
yes,
more?
we can hear you.
Yeah.
Menopause is a very big, vast subject to describe and to speak on, right? It will take much more time. Hello? Hello?
Yeah, madam.
Yes,
We
ma'am.
can hear you.
Yeah, we can hear.
Yeah, we
So
can hear
we'll
you.
talk someday. We'll talk in a deep this thing on someone.
Thank you, madam. Thank you so much, madam.
Okay, thank you for
Thank you, ma'am.
inviting me here.
Thank you so much, madam, for joining us and sharing your valuable time in spite of the crisis there. You are very kind of.
Madam, we would request you to just release our Model 21 Menopause Associated Disorders newsletter. Sahiti? Yeah.
Okay, sure. Oh, it's beautiful. It's beautiful.
This is our 21st edition.
Oh, so why don't you give it on your society activity?
We have been giving, madam,
We
regularly.
do.
Okay,
Last one
okay,
also
okay.
has it.
So all the pages should be, I mean,
We do
I
it
put-
as a flip book in the
because
group also.
I need this Sudoku and any other activities. Yeah, it's beautiful. It's beautiful. So
Yeah.
send me. This is a April activity or May
Madam,
activity?
monthly we
Okay.
release a model. I put it in that
President
President Secretary
Secretary
group also.
Okay.
After all these, usually we
So
put it.
whatever I feel like, I'll take the screenshot of that page and I'll put it in the newsletter.
Oh,
IMS newsletter, right? Is it
Okay,
okay?
I'll send the
fine.
flip book to you, madam.
Okay,
as
sure.
well. Yeah, please.
And whatever I feel like, I'll take the screenshot and I'll send it in my IMS newsletter.
Sure, ma'am.
Okay.
Thank you.
Right? Okay.
Thank you.
Thank you for giving me this opportunity. I'm so much happy to be here. But I have to rush now. They
Please,
also
madam.
need me there because there are
Yeah.
so many doctors. Okay?
Okay.
Yeah.
Thank you. Thank you very much. Bye.
So,
And we are really very happy to have Dr. Sarla Gopalan as our guest of honor, whom we really look up to. Sort of Bhishma Pita. She's senior member of RCOG and of course Menopause Society, retired director PGI Chandigarh. Okay, and we all of us have read her books, and we are really thankful for all that as students too. Okay, so shall we continue? Okay, ma.
yeah, madam. Thank you so much, madam. So we seek the blessing of the Almighty. And can Sahiti, can you play the song Invocation? We seek the blessing of the Almighty. Yeah. So we go on to our session. So first set of chairpersons, may I request Dr. Premalata Madam, Dr. M.G. Dhanalakshmi Madam, and Dr. Mohana Pramila to join the session and take forward the first session. So for which I would like to request Dr. Mohana Pramila to introduce our first speaker, Dr. Muthukumaran. Can I have Dr. Mohana Pramila's CV, please? Sahiti? Yeah. So Dr. Mohana Pramila is a fertility specialist and a laparoscopic surgeon of Sri Narayana Medical College. And she had her ART training in Singapore. And her special interests are mainly high risk obstetrics. And she's been a national faculty in various conferences and also has presented papers in various conferences as well. So over to Dr. Mohana Pramila to introduce the first speaker, Dr. Muthukumaran, the endocrinologist.
Thank you, ma'am, for the kind introduction. I welcome Dr. Muthukumaran sir to speak on Dr. Muthukumaran sir. He is a managing director and consultant endocrinologist, Arka Center for Hormonal Health Private Limited, Chennai. He had a postgraduate training in UK, internationally accredited training in internal medicine and endocrinology. He has a research degree, MD, in University Newcastle upon Tyne, UK, in diabetes and genetics. His special interests include insulin resistance, metabolic syndrome, patient education, genetic and prevention of diabetes, thyroid cancer, and genetic endocrine disorders. He is a president Endocrine Society of Tamil Nadu and Puducherry from 2024 to 25. Honorary Secretary Endocrine Society of India 2015 to 18. He was the Honorary Secretary Endocrine Society of Tamil Nadu and Puducherry from 2019 to 2022. Welcome, sir.
Thank you so much, ma'am. Thank you for the warm introduction. Am I audible?
Yeah, very well, sir.
Thank you, ma'am. Can I share my slides first?
Yeah, yes, please.
Can you see my screen, ma'am?
No, sir. Did you share, sir?
Yes, 1 second. I'll do that again.
The green arrow mark below.
Suddenly, the screen is shown.
There's a small arrow mark below, sir.
No. I've lost the screen of the Zoom.
Just go back and come, sir. Sahiti, can you help, sir?
Sir, please try clicking Alt plus Tab, sir, so that the other windows also you can see, so that
Yeah, this is a Mac, ma'am.
Alt Tab icon and Alt.
This will not have an Alt tab. Can you tell me something for the Mac?
Just slide it, sir. Maybe it has gone to the other screen. Just slide it sideways.
I can see only you, ma'am. That's the problem.
No, just slide your screen, sir. It must have gone to the next screen, next window.
Can you see me?
Yes,
Yeah,
sir, yes, sir, we can see you.
Can you see now?
No, sir. Have you touched the share screen button, sir?
Yes, ma'am. Yes, that's when it crashed. So
Okay. So can we mail the presentation to Sahiti or to me?
yes, ma'am, I can do that.
Meanwhile, we'll ask Dr. Sarveshwari Madam to take up her talk.
Shall I log in just one more time quickly?
Yeah, sure, sir, sure.
Yes, sir.
Be better.
So I think you must have lost that window, sir. Can you just keep scoring sidewise to see whether you are able to get into that window? So you are muted, sir. Sir, you're muted.
Yeah, done, ma'am.
Yeah. So you got it?
Yes.
There's a green button, no? Share. Lower down.
Yeah, I've seen that, ma'am.
Yeah, just click on that, sir. And you have to open your presentation and put it on the desktop.
Yeah. This is where it doesn't seem to go wrong.
Okay. Just open your presentation, sir. And
I've done that, ma'am.
and just reduce it a little bit and then click on the share. Click on the share, sir. So can you at least mail it to me, sir? Mail it to me or Sahiti?
Yeah, you can ask the second speaker to start, ma'am. I'll just mail it to you.
Yeah. So Sarveshwari Madam,
Yeah.
Madam, can you take your talk now?
Yeah, I thought it would be nice if he talks first because he's giving the
Right.
introduction about the hormones.
I can send it straight away, ma'am.
Okay.
Yeah, just wait a few minutes and
We'll wait. Then, sir, can you please mail it to me, sir?
Yeah, I'm sending it straight away, ma'am.
because this will be the basics actually.
Okay, fine.
Interesting topic.
That's done, ma'am.
Yeah, okay. You're able to see?
Yes, ma'am.
Yeah, sir. It is there, sir. You're able to
Yes.
see, right?
Yes.
Yeah.
Thank you so much, ma'am. Thank you.
Thank you,
I
sir.
apologize for it. I couldn't get it on my screens for some reason. Thank you so much for the Chennai Menopause Society. Good afternoon, everybody, friends, colleagues, and senior colleagues as well. Shanti ma'am as well for the warm invitation. It's a pleasure to be here, and thank you for inviting me once again. Before I move, this is our invite for Trendo for this year. Please feel free to join. We've got a 2-day endocrine program, and we have got also our Oxy Symposium. So you can just, if anybody is interested, please contact me. Next slide, please. Can I take over, ma'am, or is it possible?
Yeah, please.
Yeah. So what we are going to talk about today is the postmenopausal, primarily as we talk about a lot about menopause, the hormonal changes in menopause, we tend to forget what happens on the side in women's healthcare immediately prior to the perimenopausal phase or even in the postmenopausal phase. So there is a lot of economic data surrounding women's health, how much it starts late, but it takes over almost the whole system. And even at some point, 75% of the healthcare funding is related to women's healthcare. And this is only data from the US. Next, please. And what things have changed is our time or age at menopause has remained the same, but our life expectancies over the last century has changed dramatically from 40 to 50 years to a normal average life expectancy of around 80 currently, wherever you go. Even rural areas, the life expectancy is going high, which means most women are going to spend about 40-50% of their lives in the postmenopausal phase. So it doesn't come without a cost, and it comes with a huge cost, which is whether to live your life happily with no diseases post-menopause, or there is a big baggage which comes with your post-menopause if you do not take things correctly. Next slide, please. This is just to tell you where we put it. Most of the conditions, what we talk about is a couple of years or running immediately after menopause. So you've stopped your cycles and there are dramatic changes due to reduction of estrogen, which happens to women post-menopause. Next, please. Next, we'll skip the slide. Yeah. Next. So you get hot flushes, mood changes and all, but what happens is there are also bone changes, autoimmune changes, cognitive decline, and also a humongous cardiovascular risk associated with menopause. So this is primarily related to decrease in circulating estrogen levels. There is a change in ratio of estrogen to androgen. There is also reduced sex hormone binding globulin, which means that available testosterone becomes more prominent and more active, and then peripheral aromatization happens, and then estradiol, there is a reversal of estradiol to estrone, and then even with the same testosterone levels, you get hyperthecosis and hyperandrogenism because of the reduced sex hormone binding globulin. Next, please. So what we're primarily looking at is the postmenopausal years, which carry a lot more lifespan, like 40 to 50%. Next. So primarily my talk is related to 3 areas of life, and one is the thyroid problems. The second, what we are going to talk about is bone health, what happens immediately after menopause. And the least talked about is the last one, which is the cardiovascular risk associated with menopause, which is often forgotten. So as we know, thyroid problems are commonly discussed everywhere, and both hyper and hypothyroidism are common, whether you take fertile women in their 20s to 30s, whether you take the midlife women, and at menopause also. There is no connections directly related to menopause, directly linked to autoimmune conditions, but there is an increased prevalence due to various symptoms which are confused, and the patients are getting more evaluated due to their multiple symptoms. What is the normal TSH? it varies within a particular range, whether you take your TSH multiple times in a day or multiple times in a week. They have a normal thermostat, and everybody has got their own thermostat. So it varies within 10 to 20% of that. Next. And there is a huge relationship between your age, gender, your body mass index. If you're morbidly obese, that can itself put up your TSH a little bit by 2 or 3 points. So in a grossly obese woman of 150 kgs, a TSH of 4 to 5 might be a normal thing. And iodine intake will also change your levels, and various countries or people from different genetic origins have their own thermostats or thermostats, which put them at a higher risk or lower levels of TSH. For example, we think that Indians and Chinese carry a higher risk, a higher level of TSH compared to Westerners or white Caucasians. So these are all data which is currently evolving and recently has been noted in the recent past, or at least in the last decade. Thank you. Next slide, please. Then coming to our free T4, the T4 is tightly regulated by the TSH, and any small changes in free T4 levels will cause huge changes in TSH levels. So this is what we call as a log linear relationship. Any small changes in mean 0.1 change of a free T4 will have a change in 10 or 20 of TSH. So this happens a lot of times when clinically you do a test one day and the second day you repeat the test, there is a 5 or 10 point variation in your TSH. So that's why there is a log linear change. Next slide, please. And as we get older, we all have higher TSH, but if you see the middle part of the graph, there's a huge divide between men and women, which shows that during this menopausal or postmenopausal phase, there is excessive incidence of hypothyroidism or a borderline level TSH raise, and which this is not been, we don't know the reason why this happens, but there is a sudden significant change during the perimenopausal or the postmenopausal age where there is high elevated TSH in women. Next slide, please. So as we move or get older, the TSH level goes up, and as you get older than 65, the TSH even jumps further. And at 65, 70, a TSH of even 8 or 9 might be a normal thing. And this is not associated with any risk factors or additional cardiovascular risk. So we presume, or the data currently suggests, that if an old person at the late 70s or early 70s have got a higher TSH, this might be just a physiological adaptation rather than affecting outcomes. So a borderline TSH when people get older or women get older is not a problem in itself. Only with symptoms or abnormalities associated with it, we advise treatment or alter change. Next slide, please. So what we look at is we need to consider TSH risk, specific changes for age groups. That is one thing. Treatment decisions have to be made on patients with symptoms, patients who have got antibody positivity, and their comorbidities have to be taken in account. The starting dosage has to be taken into account as well. So if somebody is very old, then you start with a lower dose. Or if they're frail and elderly, then you just wait and watch. So these are the implications of treatment strategies in midlife women. And sometimes you just need to wait and watch rather than starting or labeling somebody with the hypothyroid label. Next slide, please. So I just not dwell on this slide, but implications for treatment. We want to primarily reduce overdiagnosis. Just by somebody having a TSH of 5.5, you don't need to give them a label of hypothyroidism. We do not want to give patients unnecessary prolonged treatments where it is unnecessary. And this can be more effectively done with evolving genetic data, doing a personalized risk assessment. This is not widely available yet, but this might be the future. And your levels, symptoms, and a good history will guide you in making these clinical decisions. So these are all things we take into account while doing the thyroid treatment plan in a midlife woman. Next slide, please. One change where whatever I've said is different, is currently again evolving. This is a graph from a meta-analysis. And if you want to treat somebody with high cardiovascular risk, then that is a good reason why you want to treat them early and aggressive with subclinical hypothyroidism. And this meta-analysis suggests that if you've got a high cardiovascular risk and you're between 50 to 65, then you might need thyroxine to protect your heart. Whereas the same thing happens above 85, this doesn't hold good, and you might be putting the patient at risk of atrial fibrillation or even osteoporosis. Next slide, please. Next. So who should we consider in midlife who have got overt hypothyroidism or signs and symptoms suggestive of hypothyroidism, age less than 70 years, TSH greater than 6 with the goiter, even pregnancy is an exceptional condition, or high cardiovascular risk, those who have got ischemic heart disease, diabetes, or dyslipidemia. Next slide, please. So next. So this is my summary slide. So anywhere between 4 to 10, we do not need to start immediately. Work through the patient's symptoms. They can easily wait for 8 to 12 weeks. You repeat the TSH test and then decide whether they need to go on levothyroxine. Obesity is not a sign of levothyroxine deficiency, and obesity is not directly related to hypothyroidism as such per se. And treatment, often if you treat subclinical disease, patients think that they will lose humongous amount of weight after starting their 25 micrograms of thyroxine, and they will just come back to you saying that nothing has changed and they'll be just unhappy. Next slide, please. So our second part of the talk is postmenopausal bone loss, which is a major health threat for most of our patients, especially postmenopause. And a significant proportion have osteopenia, which is about 40% of women, and a smaller proportion have osteoporosis. And most of these are at a higher risk. This is a continuum rather than differentiation. So if you look at, there are not, most people with osteoporosis will be at a higher risk of fracture, whereas osteopenia also increases your risk of fracture. Next slide, please. Next. So if you look at the annual incidence of common diseases in postmenopausal women or women of older age, the most commonest thing is an osteoporotic fracture, which happens in about 15 lakh people annually in a country like the States. Second comes only the heart attacks or strokes or even breast cancer. So osteoporotic fractures are very, very common. They're not uncommon, but a lot of the times we do not diagnose them proactively. Next slide, please. So if you look at the projected osteoporotic hip fractures, even in a country like India, is going to be very, very high. And 2050, it's going to be 4 to 5-fold more. Next slide, please. Can I have the next slide, please? And what is the problem with having a hip fracture? 50% never ever fully recover. 25% are nursing home or bound by somebody else's help. There is a 25% mortality within the first year of having a hip fracture, and their lifetime risk after a hip fracture is compared to a patient with advanced breast cancer. So this is the unfortunate story behind hip fracture. But in India, the story is even worse. The bone mineral density is even worse for the same age. We carry a lot more vitamin D and calcium deficiency. And unfortunately, our fractures happen 10 to 15 years prior to what Western women have. So that's where the data goes really bad from moderate to worse. Next, please. So when does this bone loss happens? And this happens immediately post-menopause. And if you look at previous slide, please. So basically, until you're 28, 30, you start to gain bone mineral density. The bone mineral density is almost stable until the age of 40, 42, and then starts climbing down. But if you look at the age at 45, it starts dropping down. And once you're into the advanced perimenopausal age, your estrogen comes dropping down and your bone loss is aggravated. Most of the bone loss, which is around 50%, is lost in the first decade after a woman achieves menopause. Next slide, please. So this is kind of one study which is elegantly showed the cancellous bone is a weaker bone, which you can see changes quickly, and the cortical bone, it takes time, and you have rapid weight loss after menopause on the cancellous bone, and that's continuing loss when you compare to men who are at a very slower phase. Next slide, please. And what you do with estrogen, if you give in this another study, which is to just kind of tell us what estrogen does to the bone. This is a spinal QCT image, where if you give HRT to patients, their cancellous bone maintains the bone markers and the osteoporosis is stopped. So the bone loss is arrested, in fact, both in your cancellous bone and cortical bone just by giving HRT. And this study was done post-oophorectomy, and they all received estrogen after that. Next slide, please. Next. So the clinical challenge, what we face in these patients is patients are often asymptomatic. Until fracture occurs, we do not know who is at risk. Even when they have 2/3 of vertebral fractures are silent or asymptomatic, unless you do an X-ray or a DEXA scan, it's not visible. So we need to identify patients who are at a higher risk of fracture and prevent the first fracture. Next slide, please. And this is the remodeling cycle. I've just given you osteoclast activity, remodeling phase, and then bone reformation happens. Next slide, please. And this is a cycle which happens and which is dependent on your vitamin D, your parathyroid hormone, your steroid hormones, thyroid hormone, growth hormone, and vitamin C, K, physical activity, and nutrition. The bone remodeling is an active process continuously happening in our bone, and it completely reworks itself every few months. Next slide, please. And what it does by remodeling is maintains the architecture. So you have the struts in between the bone, which we call as, and once you lose the struts in osteoporosis, you become weaker. Next slide, please. And this is what happens in osteoporosis. The left is a healthy human iliac crust biopsy. Whereas the right one is an osteoporotic human iliac crust biopsy, which has less struts, thinner struts, leading to osteoporosis. Next slide, please. Next. And when there are struts, you just lose the bone and fracture happens. Previous slide, please, ma'am. So how do we find these women who are at an increased risk? Unless you do a DEXA scan of their lumbar spine and femur, you will not know. And the radiation is very minimal in this test, like 1/10 of an X-ray, chest X-ray. So it's not highly radiation, and then a software defines the bone mineral density. Next slide, please. And you get pictures like this where you can see even fractures. It gives an estimate which tells us how to treat our patients. Next slide, please. Due to time, I've not explained what a DEXA means, but there are various kinds of treatments today available for osteoporosis, which are very effective. From oral bisphosphonates, we have injectable bisphosphonates. Denosumab is a monoclonal antibody, which we use regularly, and synthetic parathyroid hormone also. There are some newcomers as well, but these are commonly used for our postmenopausal women. Next slide, please. And vitamin D is something which we, in osteoporotic women or osteoporosis prevention, we would like the vitamin D levels to be above 30. Next slide, please. So in whom to do a BMD test? Anybody greater than 65, regardless of their clinical risk. If somebody is postmenopausal, has a history of bone loss, steroid use, or hyperparathyroidism, if they've got a family history of osteoporosis or osteoporotic fractures as well, they are at a high risk. And somebody who has already had a fragility fracture, low fragility fracture, will also be. But some of them, we would probably directly treat them if they've got a low fragility fracture. Next slide, please. So other than pharmacological treatments, a balanced diet, good calcium and vitamin D, appropriate exercise, reducing smoking, and falls prevention measures are also advocate as we get older. Next slide, please. So in bone health, we would want to achieve maximum bone loss as before as we can, that is during younger days. Adequate calcium and vitamin D if you suspect osteoporosis is necessary. 50% of your bone is lost between the age of 50 to 60. So whatever you try to institute, do it as early as possible, even during perimenopausal phase helps. Adequate vitamin D and calcium are essential. And make sure your patient is getting adequate calcium as well if they are on any osteoporotic treatments. The general recommendation is between 400 to 800 IU, but we know this is this is very inadequate for most of our patients. So we give them a depot dose of vitamin D and then start with basically regular vitamin D at around 2000 IU per day. Last but not the least, I'll just go through briefly this patient. This is about cardiovascular risk. A 55-year-old obese woman comes to your OPD. She has stopped her diabetes medicines. She's got very high uncontrolled blood pressure. Sugars are very high, HbA1c 8.2 and dyslipidemia. And what do we do with her? And this is one thing often neglected because women without symptoms, they tend to be just ignored, mostly even in hospitals or even at home. So they are not seeking medical help for cardiovascular risk. Next slide, please. So CAD or coronary artery disease is an important cause of mortality in women, and with diabetes, it's even worse. And with the increasing life expectancy, more commonly sudden deaths are also more common. When cholesterol and hypertension joins it, the risk is even higher. Next slide, please. So with diabetes, postmenopause, what happens? Your coronary artery disease jumps by 3 to 4-fold. Sudden death is higher by 50%. Loss of postmenopausal protection is there. Young women are protected by the estrogen, whereas once you achieve menopause, you do not have that protection anymore. So you're more likely to have severe disease. And whenever you present with severe disease, sometimes women present atypically as well. Next slide, please. Another reasons is coexisting cardiomyopathy because of uncontrolled diabetes, and revascularization procedures or restenosis is also more common in women. Next slide, please, ma'am. So what is the reason for accelerated atherosclerosis, which is one is the uncontrolled sugars, the associated obesity, cholesterol, hypertension, bleeding disorders, oxidative stress, which is associated with all the above, and high insulin levels, which aggravate atherosclerosis as well. Next slide, please. So sometimes they present with classical symptoms. It can be most of the time with painless ischemic symptoms as well. Complications like heart blocks are very common in women, and atypical symptoms are also more common in women. Next slide, please. So resting ECG has got a very, very low sensitivity. If your clinical history suggests of IHD, get them evaluated. That's all. Next slide, please. So it can be anything from a stress ECG, stress echo, angiography. Your cardiologist would be able to help you with this. Next slide, please. So address the sugar as early as possible, and consistency to sugar management. We know that too low is not good. Too high is also not good. We want good control. Good stable control is much better in coronary artery disease. Next slide, please, ma'am. Hypertension to be managed. We want the blood pressure to be less than 130/80. Each 10 millimeter of mercury gets your heart attack risk down by 10 to 15%. So next slide, please. And it can be all the cardioprotective drugs are appropriate when the patient has diabetes and menopause. So antiplatelet agents, beta blockers, ARBs, and most of them, if they are suitable, should be given all these medications. Next slide, please. Next. The patients need So a statin, definitely if they've got diabetes and postmenopause put together, anybody over 40 diabetes, they will need a statin. And depending on their risk, we want the LDL. If they are at a very high risk, the LDL needs to be below 70. If they are at a moderate risk, we want the LDL to be less than 100. The benefits of statin starts from day one, with all these parameters getting reduced from endothelial dysfunction to reduction in events. So statin is the drug of choice. There are other alternatives for other things, but your primary agent is your statin. Next slide, please. So with all this put together, there are other things as well which we advise for cardiovascular risk, bone health, and things. So to summarize, we also prioritize with medical management a healthy diet, regular aerobic activity with some resistance training, especially with osteoporosis. Some weight training is helpful, which is we advise 2 days a week with minimal weights. Inactive activities are a big burden in today's world. What I mean by is your mobile phone activity for prolonged periods, television watching for prolonged periods is a big additional burden, aggravating all these factors. Sleep alteration is also linked to all the above, and we would address most of these risk factors with the medical managements I've discussed earlier. Thank you so much for listening, and thank you so much for changing the slides, ma'am.
Yeah, thank you so much, sir.
Thank you, sir. Thank you, Muthukumaran sir, for bringing out the entire gamut of symptoms and diseases expected around menopause. And good thing you brought out about the supplementation of thyroid hormone around menopause, and whether to need supplementation, you have to really prove that you need supplementation before prescribing on thyroid tablets. And of course, you reiterated the fact that how to identify fracture-prone individuals around menopause, and how to catch them young at around 30 years of age so that you can avoid most of these problems. And of course, coronary artery disease, hardly any importance is given to women when it comes to coronary artery disease. I think we as menopause health, who take care of menopause health, should address this also. And thank you so much, sir, for almost covering the entire endocrinological aspects surrounding menopause. And thank you so much, sir.
Thank you, ma'am.
Do you do the thyroid test in fasting, sir?
Sorry, ma'am?
Thyroid assay, is it necessary to be done in the fasting, or can do it?
Not at all, ma'am. We don't use that in clinical practice at all.
Yeah.
It's a lot easy to do a random test and just get it away with.
But on the day of the test, they should not take the thyroid tablet. Is that so, or they can still be on it?
See, the TSH doesn't change at all with whether you take the tablet or not. It's only the free T4 which changes after the tablet. If at all they are taking it after the tablet, we advise them to wait for 2 hours for the free T4 to stabilize a little bit. As long
most of the time when they report to hospitals 2 hours after thyroid tablets, sir.
So it doesn't matter at all. We practice random testing in most women.
Yeah.
No issues at all.
Yeah. Okay.
So after 65 years, TSH of 6 value is okay. That's what we're telling, sir.
Yes, absolutely, ma'am. Yeah.
I think only in pregnancy we give we want the TSH to be really low during pregnancy. Otherwise, I think 5 to 10 is what most of them are considering normal.
If a person has had a thyroidectomy and they are on the thyroid replacement therapy, still in the TSH should be only maintained at 6 above 65 years. Correct, sir?
What we do there is, it depends 2 things, ma'am. If they are just on for benign disease, we are not worried at all. In young people, we want it to be less than 2.5. For older people above 65, the upper limit of your normal for the test. So if your test shows that the upper limit of normal is 4.5, I will stick near that. So for a 70-year-old, a 4.5 TSH on 100 micrograms of thyroxine is adequate. Unless they've got thyroid cancer, the matter is different. Then it's slightly different.
Thank you.
Thank you so much, sir.
For the depot dose of vitamin D, sir.
Yes, ma'am.
Depot dose of vitamin D.
Right. This is when I say depot dose, what I meant was basically giving 60,000 units for 8 weeks and then following it up. If somebody has got a level of 10 nanograms per deciliter and you give them 2000 IU, it will take a year for it to come up. So it won't work. So we give them the 8-week course or a 12-week course and then go to 2000 IU regularly, especially in osteoporotic women, which is, there are studies suggesting that it's a lot safer and it's also more effective to take it every day.
Normally, we give only oral by oral. There are some people who suggest parenteral IM also. What do you suggest?
Parenteral doses are a little bit problematic in old age, especially when there is a compliance issue. We have had seen patients with hypercalcemia in the past. So we generally do not prescribe or advocate that. Oral doses are a lot more safer, ma'am, especially for management of osteoporosis. It's a lot more easier and controllable.
So, does syrup and tablet make any difference? There are syrups also available, and you also have tablets of weekly one dosage.
Yeah, it's the affordability, ma'am. It's also people say it's nanotechnology and the absorption is better. They've got studies to show that the absorption is better. But if your patient cannot afford it, then having a couple of extra sachets of just a chewable tablet or a powder would do no harm. But make sure you do give a good company, because the bioavailability of some vitamin D. A few years back, one of my professors came, when he came here and took all the vitamin Ds available, half of them, the bioavailability was poor.
Okay.
I went back and checked it in the UK. There was half of it didn't contain vitamin D.
Yeah, but invariably, any patient, when you check the vitamin D, they are only deficient. I have not seen even a single person with a normal vitamin D so far.
If the patient has got normal renal function, they're young and fit, we don't need to really check the vitamin D to give 2 courses of oral vitamin D per year, or certainly not needed for giving them 2000 IU of vitamin D. In the US, they are currently using daily dosages of 5,000 to 10,000. So we don't use such high doses. So if there are no complicating factors like renal failure or liver failure or other medical condition, it'll be a lot more easier to just give them a 60,000 K sachet or a liquid bottle for 8 weeks and then continue them with 2000 IU orally every day. That will be a lot more safer.
Oh. Thank you, sir.
Thank you, ma'am.
Thank you so much, sir. So, madam, Shanti, madam, can we move on to the next talk, ma'am?
Yeah, please.
Yeah, thank you so much, sir, for your participation, your valuable time, and also sharing your knowledge with us. It was a very comprehensive and excellent presentation, very, very valuable to all of us. So we move on to the next topic. So for which I would like to invite our chairperson, Dr. Premalata Madam. So Madam Premalata Madam is the Sahiti, next slide, was the current president of OXY and also the current vice president of Chennai Menopause Society, and has a very vast experience
Okay,
Madam.
Okay, you can go.
Dr. Premalata Madam. So we move on to Premalata Madam to introduce the next speaker, Dr. Sarveshwari Ma'am.
At the utmost, I am very happy to call Dr. Sarveshwari. She's a consultant dermatologist from Sundaram Mount Medical Foundation. She has been the secretary and vice president and president of Karnataka, Tamil Nadu branch of Indian Association of Dermatologists and Venereologists Association, I think. Organizing secretary of Dermacon 2007, secretary of MCCCM. She had a lot of orations. Dr. Rajendran Memorial Oration, Dr. A.S. Tambaya Oration, and Dr. Saddarilal Memorial Oration. And she has had awards in from Indian Derma Practice Award, Lifetime Achievement Award in 2023. I'm happy to call her to give a talk on skin and role of skin and nail in midlife and beyond.
Yeah.
Over to Madam.
Yeah. So let me share Madam's presentation.
Thank you, Madam, for your kind words, and thank you, Dr. Mala and Dr. Shanti, for inviting me today. I'm here not just to get out of the clinic for a few hours, but I'm speaking to people who understand the complexity of what women go through at midlife As gynecologists, you're often the first point of contact for women navigating this phase. And I think there is real power in cross specialty conversation like this. So thank you again for having me. Today, I'd like to talk about something you hear often from your patients, the sudden, unexpected changes they notice in the skin. They often dismiss as just cosmetic, but these changes are deeply tied to hormonal fluctuations, and they offer critical clues about the broader shifts taking place inside the body. Next slide, please. So this is how when you know when you're 40, you start getting crow's feet, you start adding extra pounds, then you get this varicose veins and so many other sagging jawline. Next slide. To show it more scientifically, see the one on the left is a youthful skin, and the same person at midlife, how she starts getting crow's feet, how she's that nasolabial fold becomes so prominent. There's drooping of the cheeks, and there's sagging of the lower jawline. Next slide. Dermal changes of middle life are underpinned by reduced estrogen levels, as has been pointed out, and worsened by the effects of aging and lifetime UV light exposure. That's what we call as intrinsic aging and extrinsic aging. By intrinsic aging, I mean what is all of us go through routinely, where we say because of senescence, our skin starts aging. But here, the skin will be thinner, there'll be fine wrinkles, and there'll be atrophy of the epidermis. But if you see a person who's been exposed to too much sunlight or exposed to pollution, extrinsic factors, that is called photo-age skin. And you see how the other lady, her skin is so thick and the wrinkles are coarse, and there is photo damaging. There is pigmentation also seen on the face. So this is the difference between intrinsic aging and extrinsic aging. Next slide. The skin is not a passive barrier. So there is a lot of changes happening. It's a hormonally responsive organ, and it contains estrogen receptors, which particularly in the epidermis and dermis, which influence everything from collagen production to moisture retention and to immune response. During perimenopause and menopause, as estrogen and progesterone and even DHT decline, these receptor pathways are altered. So when these receptor pathways are reduced, collagen production is gone, moisture is gone, and even the immune responses are sluggish. So what that means in real life is the skin starts to behave differently. It becomes drier, it becomes thinner, less elastic, and slower to heal because even the vascular system becomes sluggish. So whatever, if there's any bruising, it doesn't go heal so fast. Next slide. One of the most dramatic shifts that we see, thing that we see is this collagen. Next, previous slide, please. Previous slide. The collagen collapse. That there's a dramatic shift in amount of collagen. Collagen starts falling down, reduced in volume. Elastic fibers are reduced in volume. This will affect the facial volume. What was before as firm and pumped up like becomes sagging. And there's also a very poor wound healing. In practice, this might result in increased bruising, as I told you, slow recovery from minor injuries, or even poorly tolerated aesthetic procedures. And it's not just the face, the neck, the hands are all telltale signs of aging. If you see, people might have concentrated on looking their face, making their face look young by all the fillers and Botox, but they might neglect the neck folds and the hands, which give away the signs of aging here. These areas, because these areas are thinner, less protected by underlying fat, and often exposed to the sun. Collagen loss is particularly noticeable and often very distressing for women who feel they've aged overnight. Next slide. And let's think about acne. Midlife acne is not a myth, and it's not always a recurrence from teenage years. It's not just that teenage acne is carrying on to midlife. Many women experience acne first time in 40s or 50s, and it is not due to excess of testosterone, but rather a relative dominance of androgens in the absence of estrogen. The sebaceous glands become more active with the slower turnover, and there's also barrier dysfunction. You get persistent papules in the jawline, cysts, and post-inflammatory pigmentation. These women, one thing must remember is they do not respond to the usual anti-acne treatment like benzoyl peroxide or retinoids or oral antibiotics. They need hormonal modulation or at least barrier restoration before we start giving any active medication. Next slide.
So this is how acne looks. Mostly it comes in the jawline. Next slide. Next slide, please.
Yeah, sure. Okay.
Next slide, please. I think, next slide, please. Hot flushes don't, previous slide, Mala. Mala, previous slide. Previous slide. Hot flushes, next one, please. Hot flushes. Next one, please. The rosacea one, yeah. Before this, the hot flushes just don't cause discomfort. They also affect the skin. Vasodilatation that occurs during flushing may disrupt capillary integrity, and that leads to visible telangiectasia and rosacea. So there is declining, or because of this, there is declining oil production and barrier dysfunction. So you get persistent redness, burning and stinging sensation, and product intolerance. Patients think they've developed allergy to some skincare products, but what they're really experiencing is a reactive skin barrier triggered by hormone instability. Next slide. You can see the telangiectasia on the left side, and the very famous actress who's always having this acne rosacea on her face. Next slide. Xerosis or dry skin is also not just a cosmetic problem. And as doctor was saying, many of the perimenopausal women or postmenopausal women are on statins, and statins will also dry the skin more. And if you use harsh chemicals, that's going to dry the skin more. I always say the skin bend, like how the soil becomes dry and cracked when there's no water, so also the skin dries up when there's no water. So the importance of applying moisturizers immediately after bath is, as soon as the water gets into the hair pores, when you put on the moisturizer, it acts like a plastic film, preventing the water from coming out and makes your skin supple. So that has to be always remember to apply the moisturizer within 5 minutes after bath. And some women can experience generalized pruritus, which might be worsened by either too much of heating or too much of cold, or even certain non-absorbable fabrics. Histologically, we see thinning of stratum corneum and reduced lipid synthesis. And there's also impaired natural moisturizing factors that we normally have in our skin. Next slide, please. So this dry skin can lead to itching, and that's what we call as asteatotic eczema. Asteatosis means not lack of oil, but it's because of lack of water that we're getting this asteatotic eczema. Next slide. And we have melasma and solar lentigines as well, both of which tend to worsen during menopause, especially in women who are on HRT. Estrogen plays a role in melanocyte stimulation, and while the evidence is mixed, we do see a subset of women developing stubborn pigmentation that are hormonally and UV driven. This is an area where both dermatologists and gynecologists can collaborate when choosing HRT options in patients who are concerned about their melasma or about pigmentation. Next slide, please. Lower estrogen also compromises epidermal barrier integrity. So the skin is the greatest barrier. Nothing gets into our skin when it is all intact. But if there's one dry patch or one scratch or any inflammation, all sorts of allergens or even infectious agents can getting in. So this makes it more susceptible to environmental results, and can manifest in many ways, things like perioral dermatitis, especially when you're using the wrong cosmetics, seborrheic like facial flares, and contact dermatitis as well. Even heat from hot flushes can worsen barrier damage, particularly when it's frequent and intense. Next slide. Going on to hair, female pattern, we have patterned hair loss. We call it as patterned hair loss. Male pattern hair loss is different, and female pattern hair loss is different. Male pattern hair loss, if you see, it will start from the vertex and go on to the center, and you'll get a U-shaped complete baldness where the hairline margin is gone. But luckily for us in females, though there is diffuse hair loss, it starts as widening of the parting that we have. The parting area widens, but luckily for us, the hairline margin is retained. So we won't appear bald unless when we bend down and show, you can see there's thinning of the scalp or there's widening of the hairline of the parting. But luckily for us, the hairline margin is retained. Next slide. So you can see the parting is getting widened. Next slide. It has a strong genetic predisposition. Not all women will show this. There is a mode of inheritance, I think, is polygenic, and they inherited both from the father side, the male, and the mother side. Currently, it is not clear if androgens play a role in FPHL. Majority of women with female pattern hair loss have normal levels of androgen. So we don't know whether the androgen is playing a role or whether even estrogen is playing a role. Next slide. Next slide. Estrogen also, previous please. Previous ma. Estrogen role also is uncertain. Though some people say that after menopause, there's more incidence of female pattern hair loss, but the lab studies have not shown that estrogens may actually suppress hair growth, or I mean, actually can help hair growth. Next slide. Treatments available for FPHL there, but there's no cure. Must tell that to the patient clearly. We can maybe only retain what you have, but we cannot give you back your luxurious hair. We can make your baldness less evident. So the FDA-approved drug is topical minoxidil solution, but unfortunately, as many of you may know, as long as you're using minoxidil, the hair growth continues, but the moment you stop, it goes back to square one. So many people are not, after reading about this, they're not very comfortable in taking applying minoxidil, but that's the only thing. Since we're going to use it only for a few more years, maybe as long as you want it, you can continue with that. And once started, treatment must be continued for at least 6 months before you can see beneficial effect. And oral medications that block the effects of androgens like spironolactone, cyproterone, flutamide can also, finasteride can also be tried. Finasteride in postmenopausal women. What is currently recommended nowadays is a low dose of oral minoxidil, 2.5 milligram per day with spironolactone. It improves hair growth significantly. Only thing is oral minoxidil, we should warn the ladies that they might start getting facial hair. So some of them are not bothered. They said that facial hair I can manage, but I want my baldness to disappear. But some of them are anxious about facial hair. So you have to leave it to the patient's decision whether they want to take this oral minoxidil, but it works very well. Next slide. So other treatments, not treatment options, but other options when they don't want any of these medications is you can use colored hair sprays to cover thinning areas. You can use hair bulking fiber powders. They're all very easily available. Hair wigs are beneficial. Hair transplantation is not very much recommended. It's not suitable for everyone. Low-level laser therapy, there is evidence, some evidence for this, and it can help. Platelet-rich plasma injection, we have found it more beneficial in male pattern hair loss rather than in female pattern hair loss. Next slide. There is another condition called chronic telogen deficiency, where this hair is continuously falling. Here, it doesn't follow this female pattern parallel. It doesn't show this partning widening, but instead, on the sides, in the parietal area, you see thinning of hair. We don't know the cause for this, but we don't need to give any minoxidil internally or even all the spironolactone or any of those. But we can try to give them protein supplements and topical peptides, which are very much common in the market, and any hematinics could also help. But reassurance, tell them the hair cycle, how it comes. There's a resting phase, there's a falling phase, there's a growing phase, and the anagen phase is more than the resting phase or the falling phase. So you can tell them it's a cycle, it's not going to go on like this, and reassurance is more important here. Next slide. So what can we do together? This is where our specialties overlap. Gynecologists are often managing symptoms holistically, like you take care of the mood, sleep, libido, cycle control, but you can also integrate skin health into this process. Here are a few suggestions that I can give you. First, acknowledge skin symptoms in your consultation. Ask open-ended questions like, have you noticed any changes in your skin? Is your skin drier than before? Such questions will make the patient open up to telling more about their skin signs. Next slide. Recognize the skin as a hormone responsive organ. And when evaluating HRT, consider this skin alongside with other systems also. Many women have reported that with HRT, their skin had become more hydrated and well toned. Next slide. And then you can give general guidance like encourage gentle skincare, not to use very harsh chemicals, and not to take very hot baths, and not frequent baths either. And even as old age approaches, to use less of soaps or to use more moisturizing soaps. Reduce fragrant containing products, cosmetic products, and use, as I told you, moisturizer is very important, very much must be stressed upon. It should be a regular affair. I always tell my patients, just like how you bathe every day, remember to put on a moisturizer every day. That's most important. And too much of looking into the net and using overall of retinoids or alpha hydroxy acid, especially in sensitive individuals, must be very careful. Next slide. We have to support collagen synthesis also, like we can give topical retinols, vitamin C, peptides, and photo protection mainly whenever they're going out in sunlight, even infrared rays, or even when they're cooking, so especially when the people are having photosensitive eczema, I tell them to use for a photoprotective chemical which acts both against UV rays and infrared rays, which even while they're cooking. So that helps them, especially when they're having pigmentation and all that. A broad spectrum sunscreen is very important. And if there's one product that you have to use is use a sunscreen. Next slide. Next slide, ma. And don't ignore acne as well, because acne, people think it's a sign of young. It usually comes only in young age, but it can come in perimenopausal age also. So depending on severity, you can add either spironolactone or even low dose oral contraceptives. That is depending on your expertise. And just before I finish this summary, a word about invasive procedures like botulinum toxin, which reduces dynamic wrinkles, and dermal fillers like hyaluronic acid, chemical peels which reduce pigmentation, which increases the tone, and laser treatments, ablative and non-ablative, which will take care of the fine lines, are all very popular nowadays and demanded by most patients. So that can be used as and when you think is important, or when the dermatologist thinks is important, along with the consultation with the dermatologist, this can be encouraged. So I think both of us together, the gynecologist and dermatologist, can give very concise and a compassionate care to our midlife women. Thank you so much.
Thank you, Dr. Sarvesri. They have taken us through all the changes which occur in midlife for the skin. Actually, I'm really happy. People always come with the complaints of itching, all generalized itching, pigmentation, and so many. Apart from the wrinkles and all, they have mild symptoms which they don't tell us.
Yes.
And as you told in the consultation, you should be asking them leading questions to come forward so that we help them. And all the dermatologists, you always emphasize on moisturizing agents.
Yes.
To be applied every day, just after taking bath, you are telling. Should
Yes.
it be applied once, or many times the patient says midnight, they have a lot of itching. I don't know, generalized itching, no arterial rashes.
Yes, that's true, madam. Most of them, especially the lower legs, they complain of itching. That's because maybe the of the cold air also there, or most of them sleeping in the center in an AC room. So I always tell them, even before going to bed, wash your legs and apply the moisturizer and lie down. That helps a little much better. Or again, even if they're disturbed in the sleep, they can always go and just wet their legs and apply the moisturizer. It will help them relieve the itching. It's only the dryness which is causing the itching for them.
On personal experience, madam, coconut oil soon after taking bath helps a lot in alleviating the itching, madam.
That's true.
I mean, I just
yeah, no, but the only thing, coconut oil works only for a short while, madam. We have also discussed that, but we found that coconut oil works only for a shorter time, but whereas the other moisturizers available works for a longer time. So if people are comfortable with coconut oil, we encourage them to do that also. No harm at all.
especially when they apply it soon after taking bath.
But yes, that's important. That is the most important point.
Madam, one question, madam. People are into instant glow now. So there's a bunch of this IV launch, NAC injections and all that. What is your thought on that, madam? They are, constantly taking all of that and having an instant glow. So do you think it should be recommended?
I don't recommend this at all, because most of them are already on IV glutathione, or they're taking glutathione tablets. As long as they put the IV glutathione, or as long as in these tablets, their skin has a glow. Once they stop it, it comes back to square one. I've had people coming and sitting. I was golden brown when I had this injection. Look now how dark I've become. So this helps in people who are in the media, or who are just going for a serial, the serial actresses, or an actress who has to. Who's going for a movie. Such people, it might help. But regularly, I don't know why many of them are already on this. So I only tell them it's important that you do your blood tests just to check that all your liver functions are normal. I've had a patient whose BP shot up when he had IV glutathione, and then sometimes they can have ventricular arrhythmias also. But mostly, most of them are safe only. All the young dermatologists are giving IV glutathione left and right. It's quite safe, but it's up to them, because as long as they take it, it's beneficial. Once they stop, it goes back to the same level of pigmentation.
Yeah. So what about those chemical peels?
Madam?
There is a question in the chat box. Best moisturizer.
Any moisturizer which is glycerin based or cetyl alcohol is useful, madam. I don't want to. I'm not supposed to be telling brand names, but to help you all, the common, very good moisturizer for any sensitive skin is Cetaphil moisturizing lotion, which is very good. You can try that for yourself. Or even white petroleum jelly, plain Vaseline. Only thing is little sticky. So people don't like a white petroleum jelly, but you can use other cream-based moisturizers. Cetaphil is one brand.
Madam, now collagen is coming as tablet. One company is coming with
Yes, madam.
Biosil that's good for skin,
Yes.
nail, and you say all midlife women, you can give us a substitute it for, especially for skin, nail, and also for early osteoporosis, something they are telling. Madam. What is your thing? Oral
Yes, madam.
tablet, madam.
Oral tablets are being given, madam. But just give it for a short while and give a break and then ask them to come. Like how you do for vitamin, the fat-soluble vitamins like that.
Okay.
But collagen are generally animal-based, no, madam. There are some plant-based one available.
Yes.
But how effective are they? They are really as effective as the animal products, or the plant one also is good?
No, the animal products are better. But
Uh,
some people they don't take animal products, even capsules they don't take. Such people you have no options but to give this plant-based collagen.
Yeah, there is a mixed opinion, ma'am, when they say if you're taking the plant product, then it is not a collagen at all.
That is true as well. Yeah, but
Yeah.
to satisfy them, if they're happy, see all this more than this, any preventive measures is more important than all this. That's what I would say.
Right.
Taking applying a moisturizer, taking sun protection. Even too much of sunscreen is not encouraged because you need vitamin D also. So I tell them only when they're going out or when they're outside, where they're too much exposed to infrared rays, that time to apply it. So nowadays there are so many chemicals which are called endocrine disruptors. So nowadays they are trying to make cosmetics which do not have this endocrine disrupting chemicals. So that is so when that comes, maybe we can have another session where I can tell you those products.
Yeah, okay. So thank you so much, madam. I think for want of time, it has been very informative and also useful session, madam. For want of time, I think we have to wind up this session. And
Thank you.
thank you
So
so
much.
much
Thank you, sir. Thanks a lot.
from CMS. So we move on to the next session, for which thank you, Premalata madam and Dr. Mona Premila madam for this chairing this session. Now I'd like to invite Dhanlakshmi madam for introducing our next speaker. Madam is the professor and senior consultant in Sri Ramachandra Institute of Medical Sciences, and she's also our very active and efficient Oxy member, and also CMS. She is the treasurer. So I will request Dr. Dhanlakshmi madam to introduce our next speaker, Dr. Ramakrishnan, for the sleep in midlife and beyond. So over to you, ma'am.
Good evening, sir. I'm happy to introduce you to this audience who's eager to eagerly waiting to hear your speech on sleep disorders around menopause. He's American board certified in internal medicine, critical care medicine, and sleep medicine, obesity medicine, with a master's degree in medical management. He's a director, critical care service at Apollo Hospital and Mitra Institute of Sleep Sciences. And he's also an honorary adjunct professor, Tamil Nadu MJ University, and past vice chancellor of Indian College of Critical Care Medicine and past president of Indian Sleep Disorders Association. And we've got several awards, fellow of American College of Physicians, American College of Chest Physicians, American College of Critical Care Medicine, American Academy of Sleep Medicine, and Indian Critical College of Critical Care Medicine. Young Achiever Award, Best Doctor Award, Best Teacher Award, Vocational Excellence Award. We are eagerly waiting for your talk, sir. Over to you, sir.
Thank you very much for the kind introduction. Let me just open my slides first. Yeah. Are my slides seen?
Yeah, very well, sir.
Okay, thank you so much. So in the next about 20 minutes or so, I would like to talk about sleep in midlife and beyond. And most importantly, wanted to convey the message right up front saying that sleep problems are real, very common, and are treatable. So that is something that we will pick up. And in the next about 15-20 minutes, number one, we'll talk about sleep and sleep problems in women in general, and then outline what are the most important sleep disorders in perimenopausal women, and discuss the clinical significance of sleep problems on women's health through some illustrated case vignettes. When my topic was mentioned as sleep in midlife and beyond, I was reminded of my mentor, Dr. K.P. Mishra, a cardiologist, who always used to say that in men, middle age is 10 years older than you. Whereas in women, I think there is a more life-defining event like the menopause where you are considered middle-aged beyond that. Now, I wanted to start with saying that there is a lot of focus on non-communicable diseases in general, and the World Health Organization believes that people are dying more of non-communicable diseases than communicable diseases. Of course, COVID apart, that was a whole different situation that we felt. But in general, there's a growing burden of non-communicable diseases. And when we think about non-communicable diseases, we often think about obesity, hypertension, diabetes, heart disease, cancer, stroke. But we forget that there is something more common than all of this and can lead to several of these, and those are sleep disorders. So that's what we will focus on in the next 15-20 minutes. There has been a lot of awareness being created by media on sleep problems and why Indians are sleeping less, why is our sleep shrinking, how can we improve our sleep, and how do we diagnose and treat sleep disorders earlier. So as a sleep specialist, we see various kinds of sleep problems. Number one is insomnia, where they come to us saying they are unable to sleep. Most common complaint, I would say. Number two is excessive daytime sleepiness, saying that I'm feeling sleepy all the time, I'm feeling tired all the time, I don't feel refreshed after having a good night's sleep. And it's very common, and we'll talk about that with a case. Third group is fragmented sleep pattern, where they go to bed on time, wake up on time, but wake up several times in between, and that's what we call as a fragmented sleep pattern. Next is parasomnias, where something abnormal happens during sleep, and that includes sleepwalking, sleep talking, sleep eating. Any of those abnormal behaviors would be categorized as a parasomnia. We also see a lot of circadian rhythm disturbances, particularly considering the fact that we are a big IT hub and we have a lot of call centers where people are working at different time zones, and they work for the UK time zone or the US time zone. A lot of people are working shift work, and therefore develop circadian rhythm disturbance. Basically, they're all chronically jet lagged, and that's where their problem arises. Now, before we get into the sleep problems, I wanted to define what is normal sleep. And as you can see here, our sleep has several stages, including what we call stage 1 sleep, which is extremely light sleep that we transition when we are from awake to sleeping. Stage 2 is where we spend most of our time in sleep. Almost about 50% of our sleep is in stage 2 or N2. N3 or stage 3 is what we call slow wave sleep or deep sleep. And that's when a lot of hormonal changes happen in our system. In fact, the children's growth hormone happens maximum during the N3 sleep. And not to forget, lastly, is REM sleep or rapid eye movement sleep. The N1, N2, N3 together are called non-REM sleep, and the REM sleep happens approximately every 90 to 120 minutes. And as you can see here, the initial REM sleeps are all short, usually about 5 to 10 minutes. But in the early morning hours, when we wake up, we probably are waking up from a longer period of REM sleep. And just one trivia about REM sleep: dreams during REM sleep are what we remember, and dreams happening during non-REM sleep is often not remembered, which is why when we wake up after a dream in the morning, we do remember it quite clearly. Now, how much sleep do we really recommend and how it changes over the ages? I don't want to go into each one of these details, but most of you know that a newborn probably sleeps up to 18 to 19 hours during the day, on an average about 14 to 17 hours. And this gradually starts shrinking. And around school age, most of the sleep is consolidated towards the night, where the children sleep up to 9 to 11 hours during the night when they are about 6 to 13 years old. And then during the teenage, they're hopefully having 8 to 10 hours sleep, but considering all the peer pressure and all their additional classes, most children probably don't get that. Adults require about 7 to 9 hours, but we are accepting up to 6 hours. So 6 to 8 hours is what most people get. And this does not really change much with older adults. So even 65 plus need that kind of a sleep, but we will talk a little bit more about that as we talk further. Now, how much sleep is really good enough? If I had asked this question about 100 years back, the average answer would have been 9 hours. But today we are shrinking our sleep, and in the 2000s, several are happy with 6 to 6.5 hours and even less. And that's what we are beginning to accept as a shrunken sleep period that we are primarily due to the lifestyle changes that is happening. I do want to specifically mention that women need approximately 20 minutes more sleep than men, but most really do not get it. So women's sleep is a slightly longer requirement than what men require. Now, 60% of the women say they only get a good night's sleep a few nights per week or less. Okay, as you can see, only about 39% say every night they get good sleep. Some say never, but most of them get only a few nights a week, a reasonable good sleep. And why do they not get the sleep they need? Number one, lifestyle impacts on, like the good old days, the women used to serve the men, and then only go to sleep. So they always were the last ones to sleep and the first ones to get up, and therefore they were shrinking their sleep. But today, a lot of working mothers, single working men also are extremely experiencing, less sleep, primarily because of all the commitments they have. There are other factors that wake up women. Number one, noise. Which is a huge problem these days. And there's also something specifically called spousal arousal syndrome, where the men snore and therefore the women are unable to sleep. And there's a lot of what we call sleep divorces. Increasingly, people sleep in different rooms, primarily because they're unable to sleep when the other person is snoring. Giving care to the children, particularly during the newborn period, is an important thing. Having pets sometimes has been shown to disturb sleep as well. But beyond all of this, women have unique physiology due to the hormonal changes that can disrupt sleep. They are more likely than men to report poor sleep, but I must also add that they are less likely to seek medical help. Although they are 3 times more likely to suffer insomnia. We see more men than women because women present less. They do experience also mental health issues, including depression and anxiety, which can disrupt sleep. Once again, they do not seek help often. I do not want to go into all the physiology and stuff, but I do want to mention that changes in the hormones, whether it is estradiol, progesterone, LH, any of those, can affect sleep in two ways. Number one, it can reduce the sleep drive because it can affect prostaglandins and adenosine, or it can increase the wakefulness. So people can have what is called VASO, wakefulness after sleep onset. They go to bed, but then keep waking up, and that's primarily because of changes in hypocretin hormone, orexin, histamine, all of which can promote increased wakefulness. I wanted to briefly mention about specific sleep issues in other hormonal periods of the women's life. During menarche, a lot of them can have what is called delayed sleep phase. What happens is they go to bed late and wake up late. So they start sleeping. I mean, all of us who have adolescents or children during menarche would know this, that they start sleeping only after midnight and would love to sleep till about 9 or 10 o'clock. But if they have school commitments, they have to wake up, and therefore they are shrinking their sleep. And they can also have sleep fragmentation. Same thing with young reproductive age, luteal phase, and menses. They can have insomnia, awakenings, and a lot of them can have non-restorative sleep. Pregnancy, during the first trimester, they sleep longer and have greater daytime sleepiness. Second trimester as well, they may have daytime sleepiness that improves. During the third trimester, there's a lot of worsening of sleep disturbance, primarily because of even discomfort in the position where they can sleep. And during postpartum, the sleep fragmentation can persist. Sometimes it can even go on for about 6 months. Particularly when it comes to menopause, the common sleep disorders that we see are insomnia, and we also see sleep disordered breathing, particularly obstructive sleep apnea. And what kind of insomnia? A lot of them have what is called increased VASO, or increased wakefulness after sleep onset. They may go to start sleeping, but with a delay. That's why what we call as increased sleep latency. They may have increased sleep duration. They may have a higher efficiency, but it may be fragmented, and they may sometimes not feel fresh relating to that. Okay. A lot of menopausal women, perimenopausal women, may have hot flashes that may disrupt sleep. They have a much higher risk for sleep disorder breathing or sleep apnea right around menopause. So just like how we talk about cardiac risk factors is much less in the premenopausal group, and right around menopause, the risk is almost similar to men. Same here. In the younger age, before middle age, Men have a lot more sleep apnea, but right around menopause, women can have sleep apnea. And I do want to repeat saying that in India, we see a lot of non-obese sleep apnea. So don't think of sleep apnea only in the obese patient. It can happen just with the age and change in the hormones at right around middle age, right around the 50s. And women are also more likely to suffer from depression, mental health issues due to the hormone fluctuations, and that can also affect sleep. And just a quick note on HRT, the use of that for the sleep problems has been rather inconclusive. It really does not make a significant change. So what happens if they don't sleep well? Just imagine one night you haven't slept well. The next morning when you wake up, you feel your eyes are red, you feel like you have a headache, you feel irritable, you feel like you can't focus, you feel you're less productive, and you're probably a lot more irritable. Now, multiply this several times, and that's what happens if somebody has poor sleep on a regular basis. They can have much higher stress, daytime sleepiness. Um, socially, they could be uncomfortable, too tired for sex. They start becoming drowsy during the daytime while at work, and sometimes even while driving. And a lot of them are late to work just because they are unable to get ready and start on time. Okay. With that background, I'm just going to give 3 cases and just highlight some important issues that happen around menopause. 50-year-old women, difficulty falling asleep and subsequent frequent awakenings over 6 months, hot flashes, cold chills, restlessness and palpitation disturbing sleep, frequent arguments with husband over the temperature setting in the room because she's unable to tolerate what the husband wants. And this is something that we all face at different ages as well. Wakes up often not feeling refreshed, denies any snoring, no restless legs, no other comorbidities, just the typical perimenopausal women, maybe with some mental health issues and sleep related issues. So here, what the patient is having is what we call a sleep onset and maintenance insomnia. Has trouble falling asleep, has trouble maintaining the sleep. And insomnia is very common in perimenopausal women. Looking at the studies, it's reported anywhere around 38 to 60%, or as high as 60% in perimenopausal women. Again, as I mentioned, HRT may or may not work. And in these situations, we sometimes use medications at least briefly and then have to wean and taper them off. Of course, talking to them and in whatever else way you can help with the hot flashes and stuff would also help. But when we use zolpidem or any of the medications, we recommend a smaller dose. A lot of the times people start taking higher doses thinking it's going to work. Even with zolpidem, we've noticed that when you move from 5 milligram to 10 milligram, it may not help the sleep, but the side effects may be a lot more. So really, choose the right drug, choose it on the duration of action, how they tolerate, and try to wean them off that. How long we treat may be variable. In a lot of them, usually it is for a few months and then try to taper off. Teaching them general sleep hygiene and I'll list this towards the end of my talk as well. Cognitive behavioral therapy, psychological support may help. Stimulus control, and by that what we mean is aligning your intent to sleep with looking at the bed, a lot of those psychological counseling do help. Relaxation techniques, particularly what we call as progressive muscle relaxation just before going to bed, may help. Thermoregulated blankets and mattresses. There are a lot of smart mattresses that are beginning to come, particularly because the temperature requirement of a couple may be very different. What the woman wants may be different from the man. So having individual thermoregulated blankets may be helpful. Do all these patients require sleep study? Absolutely not. So a lot of the times just talking to them, sometimes counseling and making some hygiene changes and giving them medications may be what is required. We'll move on to the next case. 52-year-old woman with complaints of non-refreshing sleep. And his story, the husband's story, reveals that she's snoring loudly, has witnessed choking episodes, and worsening symptoms since menopause and a recent weight gain. Her story, when you asked her, says that she wakes up often in the night, and when she gets up, she has dryness of the throat, wakes up not feeling fresh, feels sleepy during the daytime, has early morning headaches, and she also has GERD, uncontrolled diabetes, and uncontrolled hypertension. Their story, the rest of the family said that she's increasingly forgetful, irritable, and not her usual self. So, classic obstructive sleep apnea, this is how they present. The common symptoms at night are loud, persistent snoring, and then, like most of them, the spouse or the bed partner might observe that they stop breathing, what we call the apneic episodes. Sometimes the person may themselves feel it as a choking episode or gasping for air. They may have a restless sleep. They may wake up often to go to the bathroom and often complain of dryness of the throat. These are all the nighttime symptoms. And the next morning, when they wake up, they may have early morning headaches. They may feel non refreshed, have sleepiness, poor concentration, irritability, and falling asleep easily when sleeping, sitting and doing nothing, and even sometimes while driving. So what we do is like there are scores that we have. The one we use often is the Epworth Sleepiness Score, where how easily can they fall asleep, and if this score is more than 10, they are described as sleepy. And then we may need to do a sleep study. There are different types of sleep studies, what we call as level 1 polysomnogram in a sleep lab, or a level 3 study, which can be done at home, does not have EEG, and it is only to find out snoring and sleep apnea. I'm not going to get into those details, but what we look at in this sleep study is what we call apnea hypopnea index, where we add up all the number of episodes of apnea where they stop breathing or where they slow down breathing, average it per hour, and if that is less than 5, it's considered just as snoring or normal. If it is 5 to 15, we call it as mild sleep apnea. 15 to 30 is moderate, and if it's more than 30, we call it as severe sleep apnea. And remember that sleep apnea is an independent risk factor for hypertension, diabetes, and particularly uncontrolled hypertension, uncontrolled diabetes, heart disease, and stroke. And there's also evidence that people with sleep apnea may be obese, and that could be causing it, but it can also lead to obesity because there's a lot of secretion of ghrelin and leptin, where ghrelin leads to increased hunger, and the leptin is the satiety hormone. So they feel less satiety but more hungry, and therefore they may eat more and become more obese as well. If somebody has sleep apnea, depending on their severity, of course, we always, if they're obese, talk to them about weight loss. There are surgical options. There's also CPAP. If it is moderate or severe, we may often go towards CPAP. If it is mild, we may consider just sleep hygiene measures, sometimes surgical or dental appliances. Again, just broadly, I want to leave it there. But here is somebody in their menopausal age developing sleep apnea that requires treatment. Okay. So we talked about this, saying that right around menopause is when men and women almost develop an equal prevalence. Lastly, 50-year-old woman presenting to the psychiatrist with history of mood disturbance, low self-esteem, crying spells for the past 6 months. Family reported that symptoms have been worse since menopause and that the couple do not have any children and had extensive infertility workup in the past. This is something that we see often. Women who are infertile, women who do not have children, develop a lot of mental health and sleep problems right around menopause because at that time they feel there's no more hope of having a child. So this is something that is typically seen. Lab tests suggestive of hypothyroidism, anemia requiring further workup, and a diagnosis of depression was made, and she was started on escitalopram. Not uncommon, and it's probably fair. A week later, she presented with abnormal sensations over lower extremities, relieved only with movement and massage. Classic, what we call restless leg syndrome. Restless leg syndrome is a diagnosis made on symptoms, does not need a sleep study. Of course, during sleep study, we can see what is called periodic limb movement disorder, but for the diagnosis, it is just symptom based, and that's what we found. And the sleep pattern worsened, and this aggravated more anxiety and depression as well. So restless leg syndrome is one where they have a desire to move their limb. Sometimes they can say tingling, numbness, just discomfort. They just feel like getting up and walking. There is a motor restlessness, and the symptoms are a lot worse at rest, and partially it may be relieved when they get up and start walking, and it's often worse in the evening and nights. It's associated with lots of conditions. Specifically, I wanted to mention pregnancy, well known, and also diabetes, chronic kidney disease, iron deficiency, even if they are not anemic. Okay, so their hemoglobin may be normal, but if they have iron deficiency, then it could lead to restless leg syndrome, B12 deficiency, and any kind of chronic pain syndrome. Those with back pain, knee pain, any of them, they can develop restless leg syndrome. Few things non-pharmacologically, what really helps is avoiding caffeine, nicotine, alcohol. All of those definitely helps. But one thing that I've noticed definitely helps is hot baths in the evening and some stretching exercise and massage before bedtime, and that really does seem to help. Pharmacologically, if they are iron deficient, then you can replace using benzodiazepines, narcotic analgesics, particularly if they have pain, may help. Pregabalin, gabapentin are often used, anticonvulsants, other medications as well, and some dopaminergic agents like pramipexole and ropinirole. Very much treatable. I've had patients who come saying that I feel like committing suicide with the restless. It can be that bad, but then like once you treat them, they are feeling a lot better. I would like to close by talking quickly about some sleep hygiene measures. Number one, what helps is having a reasonable schedule, eating on time, sleeping on time, exercising on time. Definitely does help getting your better sleep. Limit the non-sleeping bedtime. Do not lie down in bed and watch TV, read a book, listen to music. People do everything before they start sleeping. But we always say that the bed association factor, the bed is only meant for sleep and intimacy with your partner. If you can do that, it definitely improves your sleep. Unplug at least 30 minutes before. Do not just, busy at work and I'm coming straight to crash. Often does not work. Some kind of relaxation does really help. Optimizing the sleep environment, and this again is always a challenge for couples, but the right temperature, the right kind of lighting. Some people like it really dark, some people like a little light. Whatever suits you is perfectly fine. Avoid alcohol, caffeine at least about 5 to 6 hours before bedtime. Definitely makes a difference. Smoking as well. And recognize inadequate sleep early and seek help. If you feel that you're not getting enough sleep and it's persisting and there's no specific reason, it's better to get help rather than just bearing with it. And lastly, it's okay if you don't get good sleep some days. I mean, don't expect 100% sleep every night, because then you'll unnecessarily end up on medications that you may not require. Lastly, a request to all gynecologists: if there are 3 questions you can ask, you can pick up all the sleep problems early. Number one, how is your sleep at night? Are you sleeping enough? Are you getting good quality sleep? Number 2, are you feeling sleepy during the daytime? And number 3, is anything unusual happening during your sleep, whether it is snoring or restless legs or any of the parasomnia? Remember that a good night is always essential for a good day. So I wish you all a good night's sleep. Thank you.
Thank you so much, Dr. Ramkrishnan. It was a wonderful, what do you call it, speech which awakened to the many facts about sleep disorders around menopause. I think we deal with the sleep disorders when menopausal women approach us. I think we should get a combined clinical fee. Like we are not in a position to treat them entirely. I think we should refer them to proper people who conduct regular sleep clinics. And as you said, we should adopt we should follow the 7 simple habits, and ask every lady who comes to you with sleep disorders the 3 simple questions. And with this discussion can start now. So
what is
questions?
melatonin, sir? So what is the role of melatonin?
Yeah, so melatonin is very helpful in circadian rhythm disturbances. where, like during jet lag, or some of these people who are working shift work. Because what is actually happening is, I know you asked about vitamin D as well earlier. So when we are exposing our body to sunlight in the morning, our vitamin D level goes up. In the night, when you are exposing to darkness, the melatonin level goes up and the vitamin D level comes down. This circadian rhythm is kind of essential for us to maintain the rhythm. Now, a lot of people, when you're traveling across time zones or when you're working across time zones, can have problem, and that's where it is most helpful. Number two, there's also some data on melatonin in what we call REM behavioral disorders and stuff. Why I'm mentioning this is these are all where it is proven. It is not to be used routinely as something to help sleep, because unfortunately it is an over-the-counter medication in most countries, including the United States, where there's a lot of regulations. So most people are beginning to use melatonin, which are now available as gummies, so they start swallowing it thinking that it is good for sleep. It is like any other medication. If you use it for too long, it has its own side effects, but not to use it for long, but it can be used in specific situations where I was mentioning to you.
Yeah. So what could be the reason?
Sorry to disturb, ma'am. We are running short of time. We'll go ahead with the quiz, ma'am.
Yeah. So, okay, sir.
Sure.
Yeah.
Thank you so much.
Thank you so much, sir, for your valuable inputs, and also it was a really wonderful session.
Thank you. Thank you so much.
For joining us. Yeah. Okay, go ahead, Saiti.
Yes, ma'am.
Now,
First question.
yeah. See, request all to attend the quiz. Delegates are. So, what is the clinical characteristic of female pattern hair loss? Hair loss on top of head, hairline margin is lost, parting widens, and hairline margin is retained.
Hi, how are you? Dr. Sneha,
Yeah,
I can't hear you, ma.
Yes, ma'am. 5 more seconds. Time up, ma'am. Second question.
Yeah. Intrinsic aging is characterized by 1, coarse wrinkles, 2, thickened epidermis, 3, fine wrinkles, thin epidermis.
Five more seconds. Time up. Third question.
In perimenopausal women, why is it important to monitor thyroid function carefully? Thyroid dysfunction is rare in this group. Thyroid dysfunction symptoms mimic menopausal symptoms. Thyroid hormone levels do not affect cardiovascular risk. Treatment is not necessary in this age group.
Five more seconds. Time up. Fourth question.
What is the primary risk associated with untreated hyperthyroidism in postmenopausal women? A, decreased bone density and increased fracture risk. B, weight gain and diabetes. C, hypotension and bradycardia. D, increased risk of thyroid cancer.
Five more seconds. Time up. Completed, ma'am.
Yeah, thank you. I think we'll go on to the panel, and the panel is being moderated by our dynamic joint secretary, Dr. Mala Raj, who is also the coordinator of co-coordinator of this program. And Mala, it's really my pleasure to welcome Mala.
Yeah. So thank you so much, madam. So I think we are really running short of time. So I will also try to keep the panel discussion very brief. So in tune with the theme of this current year, changes and not challenges in midline, we also have the panel topic to be made in the similar manner. So getting prepared for the changes and not challenges in midlife and beyond. So, as we all know, midlife comprises a large portion of adulthood and most important life turning point event in a women's life. So, we are not only at the very beginning of understanding of this phase and also how it may differ from other periods of adulthood, but also in midlife, we need to really move beyond the misconceptions. Quite a lot of misconceptions are there present in this particular field of phase of life. So that is the reason we are having this panel with wherein we are going to have a crosstalk with all the other specialty people to have a clear understanding of what exactly is happening to that women at that point of time. So it is, in fact, it should be considered as a vibrant period with unprecedented opportunities and challenges. So it is only when the mind is really prepared to accept it, I think everything will go on in its own way. So development is a very cumulative and lifelong process, but we know strikingly little about this development in midlife. As I mentioned earlier, there are quite a lot of misconceptions. So as a consequences, many of these misconceptions exist about the nature of the midlife and the developmental milestones and the challenges faced by these women. So to throw more light on these particular aspect of all the aspects of the midlife, we have an eminent panelist with us. We have an orthopedician who is Dr. Sendil Kamalashekaran, a physician, Dr. Swati, gynecologist, Dr. Deepa Thangamani, psychologist, Dr. Napai, and also urogynecologist, Dr. Sita Lakshmi, and oncologist, Dr. Jayashree Natarajan. And introducing our panelist, Dr. Napai is a very good psychologist, and she's a rehabilitation psychologist and also marital therapist, which is very, very mandatory at this phase of life. And also she is a founder of the Sai Brain and Behavioral Clinic. Then we also have a physician, Dr. Swati Murthy, who is a professor in Ramachandra Medical College, and she has done quite a lot of research project and received the IMA Dr. Sagunan Award for the best outgoing in ENT during her MBBS days, and also published several books and chapters. And she's also the subject expert and doctoral committee member for PhD, Chettinad Academy of Research and Education. So we have various credits and accolades to her. And also we have a very good orthopedician, Dr. Sendil Kamalashekaran, who is a senior consultant in Apollo Hospitals, and also is a knee fellowship at London Bridge Hospital, and is an expert in the management of trauma, spinal injuries, sport injuries, and also he's a practicing regenerative medicine for prevention of arthritis, including the stem cells, which is also mandatory for our menopausal women. And then, of course, we have a very own colleague, Dr. Deepa Thangamani, a very eminent gynecologist from Apollo First Med Hospital, and also she's a consultant at Thamare Fertility Center, and of course our very own onco-gynecologist as well, Dr. Jayashree Natarajan, to whom we look up to when there is quite a lot of oncological issues. And also we have Dr. Sita Lakshmi, madam, our very own urogynecologist, who is heading the Department of Urogynecology in Savita Medical College, and she was the former Dean of Government Medical College, Virudhunagar. So we have a bunch of all eminent people who are going to really throw light on various aspects of these changes and not challenges in midlife, and how are we going to look forward. So the number of older women, of course, is really going up, and we have an elderly population which is really coming up. And as a result, we have new challenges, and we need to make sure that we face difficult decisions. We have to face difficult decisions, and we also have increased anxieties regarding not just our own health, but also the concerned loved ones, and also the uncertainties about the future as we spend most of our time now in this phase of life. So looking at the mental health. So let us start with the mental health. So we have just each and every consultant is going to have just one particular aspect of discussion regarding this particular phase. So to start with, I would like to concentrate on the mental health. And so as a consequence of changing mental health trends are historically rising mortality. So we have many suicides, poisoning, chronic liver diseases, cirrhosis, due to alcoholism and all those things. So because of this, we need to have a very good psychologist also to make sure we are mentally strong. So this is a common scenario which many of us would be facing, not just with the patients, we also can be seeing us in our very own family as well. So something like this, or a 55-year-old lady who just finished all her commitments, left her child to her college, and also now she requested therapy to manage a sense of overbonding and diminishing self-worth. She suddenly realized that in the recent years, she has focused all her attention only on her family, giving care for her father, her ill, and then for the last 6 years, who's been having dementia, and also to the child. And also, she recognized that throughout these challenges, she diverted attention from her very own needs, and she's now started feeling that she's no longer looking pretty. And she's also feeling that she's very ashamed because her looks are not exactly like what it was. So the aging was coming to get her, and she stated clearly that she simply did not know how to approach and accept being an older woman. So, as a mental therapist, I would like to ask Dr. Napai, how is that one can manage these kind of life crisis? I'm sure everyone will be going through this. And also, are women really accepting menopause today? And how is the family should be supportive for these women as they're aging? And what are the psychological impact that can occur due to aging? So, can Dr. Napai throw more lights on this, please?
Thank you, Dr. Mala, for this opportunity. To answer the first question, this midlife crisis is definitely a problem, particularly for women, because it's an emptiness syndrome. They find themselves not being useful to the family. At times, there are lots of complaints saying, I have nobody here, I'm left all alone, so what do I do with my time? Either there is a lot of time in hand, where they start brooding about not being given the attention that they require, which can lead to a lot of conflict with their partner. All that was there in the partner before can become a problem today. For example, the partner would have always left the teacup on the table. He would not have folded the newspaper. But today, in midlife, that becomes a major issue. And there's been a lot of cases where they've gone up to divorce. The second thing is the newfound freedom, the other end of the spectrum. There is no responsibility connected. So I have a newfound freedom, which again I would like to bifurcate as two. One, in a positive side, women engage in activities that they always wanted to do. They have a bucket list and they would like to explore it. They've gone learning music, they've started learning language, they found what their hobby was. But the other end, there are people who go into depression, or they reach out to things which are not technically so-called good. They'll end up talking to people unnecessarily on Facebook or Instagram, thinking it is nicer to hear somebody pampering them, and get into a lot of scams. They get into a lot of alcoholic behavior because there is no requirement to be back home early. So if you can see, this midlife crisis can lead to a lot of damage in the marriage, in the individual per se, where they go into depression or anxiety. To answer your second question, are women accepting menopause today? Normally I would say they're glorifying menopause today. If you ask all the people here whether your mom had menopause or your grandmother, or did you know that she was going through menopause, I don't think we knew. But today it is more glorified that even youngsters come and say, when there is a marital discord, they say, "Ma'am, I have my PMS." And that is when he asked me this. So I flared up. So I think, again, I'm not saying all of us are glorifying. There are certain women who use the internal aspect of stress or anger in the name of all the menopause, the hot flushes, or whatever is happening. And there are few women who are still suppressing this and not voicing out. But yes, there are a very few sector of people who have understood what exactly menopause is and have started to prepare about it much earlier, about the physical and the psychological aspects of menopause. And they've really started working on it much earlier. So again, I'm telling you, we have people on all ends of the spectrum and very few people in the mid ground who are accepting menopause today. Certainly, family needs to be very supportive of a woman. Men forget, or even children forget, that the mother is aging. The man sits and asks for coffee. He sits to give the tumbler to her and says, drop it there. He asks her for water. He forgets that she's equally aging. Maybe the age gap today is not as great as it was then. But then they forget to understand that the mother is aging or the wife is aging. And the support system needs to be worked upon even more in ways of accepting that she needs adequate rest. She needs to do what she would love to do. It might not be something of their liking, like talking to her friends or visiting somebody whom she likes, because that is the support system she gets when she's aging. Women might be sibling dependent. It's okay to allow her to talk to her sibling for a few hours more than normally what she was doing, because she doesn't have anything to do now. So she wants to talk to her sibling. I think the family should understand that. And secondly, when she's complaining of pain, the family should never dismiss that nor complain by saying, oh, you're always talking of pain. Why is it you're always, grumbling about your pain? It's natural for her to have the pain. It is not necessarily it is a physical pain. It could be a psychological pain as well, which needs to be addressed by the family. The family support can always make the female feel
So we are not able to hear you.
women. It's always a dance. She's always going to say, they think I don't know anything. But I'm wanting everybody to sit and talk to the family, each one of them. It is not only to the aging lady. I want everybody to have a family time, sit and talk together to show how supportive they are to each other. Psychological impacts of aging, like everybody has spoken about, it is definitely the beauty factor. And every day when she combs her hair, the one that was thick is becoming frizzy and thinner, which is very difficult. She's seeing it gray. Of course, we can dye it, but there are a lot of other problems that she might have in her skin that the dermatologist could have said no more for dyeing. And she must have gone fatter before then. The obesity is a big issue. So all these factors can lead to depression and anxiety. Like I initially said, the emptiness syndrome and the partner not being considerate about her needs or what she dislikes needs to be taken into impact. That can cause a lot of depression or anxiety or a sense that I'm lacking the sense of belonging in this family, which can again pull her down. Apart from all this, we see women during this phase of menopause becoming a bit suspicious and paranoid about their partner who's talking to somebody, more than what they were normally doing. So there can be a lot of marital conflict as well in this age. Keeping all this in mind, I think women who are going through menopause first need to have some self preparation, meet a gynecologist, meet a physician, talk to them about what is disturbing you or what is your fear about your menopause. And if required, you will have to talk to a therapist to help you come out of this. Thank you for the opportunity, Dr. Mala. I hope I've answered all the 4 questions asked for.
So yeah, beautifully, very beautifully you put forward. Thank you so much. So I think I used to think, I think the earlier days there was a difference in the age between the partners. There was almost at least 10 years. My mother-in-laws and all, they had an age gap of about 10 years. So I think that those really help the partners because the husband ages little more than the women because when the woman is in the menopause and he is also a little older. So this conflict will not occur much is what I keep thinking in my mind. So maybe I think that was one of the reason why the age gap also was important. So anyway, that was a very beautifully explained, Dr. Napai. Thank you so much for being part of our panel. So now we move on to the physical health. So we have Dr. Swati to address this. And health is where the heart is. So we all know the heart is the most vital organ. It keeps working constantly, and we need to make sure that we take care of it so that you can avoid all the complications and the metabolic diseases which are associated, and the rise in also obesity, the increase in calorie intake, and also lots of diabetes mellitus also being detected at this particular age. And of course, the cardiovascular health is the most important factor. As I mentioned, we have the heart, which is our primary focus. So for which we have simple 7 rules by the American Heart Association. I think Dr. Swati is going to enlighten us with all this. So I have a question to Dr. Swati. Why is that many women gain weight during midlife? And these are the things I would like to hear from you. And also there is an increased risk of stroke and other neurological disorders. So how can we prevent these catastrophes? And also the incidence of cardiovascular disease, risk and mortality is also on the rise. How can we avoid, and why do we see many newly detected diabetes mellitus, and what would be the best lifestyle modifications? So over to Dr. Swati, please. So Dr. Swati?
Am I audible now, ma'am?
Yeah, we can hear you. Yes.
Thank you very much, ma'am, for this opportunity to share my viewpoint on this podium here. Let me take one by one, and why women gain weight during midlife. Let me put it this way. I think most women in the transition of the menopausal age will have the commonest complaint as 1, 2, and 3 would be weight gain. This is more so, right, starting from the midlife towards the menopause and the post-menopausal period. To go with, in the premenopausal phase, women have a greater quantity of subcutaneous adipose tissue, which has a transition from the subcutaneous plane towards the visceral adipose deposition as they move towards the menopause. So this is what also reflects in the increase in the central body fat distribution. So there is a shift from almost 5 to 8% of visceral fat to 15 to 20% when they get into the postmenopausal period from the premenopausal phase. And this transition is also associated with a decrease in the muscle mass. When this happens, we also see this age as half of them would have finished their major commitments of life or on the verge of getting into their near completion of responsibilities. So they also have an increase in their food intake, increase in the quantum, as well as change in the pattern of their food habits, decrease in the adipose tissue lipolysis, physical activity comes down, and there is also a decrease in the energy expenditure. All these attribute to an increased weight gain in the female population. And these abrupt changes which happen are also associated with the reproductive hormonal changes, especially the estradiol, which decreases, and not so much decline which we notice in the testosterone, and the ratio which gets altered. All these make the individual increased risk of getting into a weight gain. And there is an increased risk of stroke and other neurological disorders in this phase. Yes. Why? Again, let that be your cardiovascular risk or the neurological disorder and the stroke risk. Everything is attributed to the hormonal changes that happen. The estradiol decreases rapidly. Androgen gradually decreases. So the ratio gets altered, and eventually it is also the sex hormone binding globulin which is low. Once these changes happen, this increases the risk of any cardiovascular risk. There are changes which are impacted on the lipid metabolism. The LDL triglycerides increase, the HDL falls low, so the bad cholesterol increases and the good cholesterol comes down. The weight gain, along with these lipid changes, central obesity, all these again increase the risk of patient getting into a metabolic syndrome. So this again eventually increases the cardiovascular risk. Blood pressure changes happen during this. Everything bound back again to the hormonal disturbances. There is an increase in the systolic blood pressure with not much change in the diastolic blood pressure. So the pulse pressure also changes. So these are max at the immediate phase or the immediate year following the menopause. And some female populations also do experience palpitations and other cardiac symptoms during the menopause, which could be partly because of the menopausal vasomotor symptoms, or it also could be because of these risk factors they are getting into an early cardiovascular manifestations. Now, how can we overcome these catastrophes? I can take both cardiovascular and neurological together. What happens during these transitions would be an increased abdominal obesity, triglycerides are high, cholesterols are deranged. The fasting blood glucose also goes up, and they start getting into other manifestations of insulin resistance. Eventually, all these are bottlenecking the risk factors together, which makes the individual more prone to get into any vascular event. There is an accelerated atherosclerosis which gets triggered because all these factors add on one to one. So what will happen? There will be an increase in the subclinical vascular disease early in the postmenopausal phase. There is an alteration with the vessel wall. The carotid intimal media thickness gets altered. Adventitial thickness is increased. The diameters in the vessel calibers are changed. So all these are triggered more so because of the androgen excess compared to the decline in the estrogen. So this doubles the risk of any vascular event. So the stroke risk gets doubled, especially 10 years after menopause. The risk is as good, equally same as a male population, or sometimes close to the 80s in the age. The risk also can sometimes increase in the male population. Now, when all this happens, we should also remember that there are certain risks which I had explained, which are attributed to an ovarian age and certain because of the chronological age of the individual. The increase in the cholesterol, LDL, and the apolipoprotein B, they are predominantly because of the they increase within 1 year of the menopause. Whereas the other changes which I had discussed about regarding the risk factors are more because of the chronological age. So invariably, chronological age cannot be reversed. So the risk which attributes because of the age cannot be reverted back. So what can change would be our modifications in the lifestyle. In the lifestyle, it is predominantly the physical training which an individual would go through. The individual should be going through some amount of aerobic exercise, a moderate activity, physical activity, at least ensuring that 20 minutes to 30 minutes per day, at least 3 to 5 days a week, is what has proven benefit in overcoming the morphological changes in the individual's body. The central obesity which develops during the midlife, which progress on towards the immediate postmenopausal period, is easily overcome by this. And with age, the muscle strength comes down. With physical activity, the resilience in the muscle improves. Other lifestyle modifications which can be accounted for would be modifications in the diet. The healthy diet would comprise of increase in whole grains, fruits and vegetables, and lean proteins. One should limit the processed foods and sugary drinks, saturated fats. Especially concentration should be on stress management, medication adherence, and the cultural inhibition that if they are not symptomatic, let them not access healthcare. That should be overcome. As we age, we know we are going to imbibe in a lot of changes with the age in body, physically as well as metabolically, which have to be catered to. Support networks at the family and outside does help them come over this. I think, ma'am, I have taken all questions together and given a gist.
Madam, thank you so much for very, very crystal clear explanations, madam. Thank you so much for your contribution to this panel, madam. So
thank you, ma'am.
Yeah, so we move on to the next question. So we deal with the urinary health. So of course, I think I will skip all of that. We are running short of time. So how can one prevent, through Dr. Geeta Lakshmi, madam, so how can one prevent incontinence and where a 50-year-old lady complaining of frequent urination, and how will you manage? And is Kegel exercises and very effective, and what is a non-invasive therapy for these things? And also more than that, I would also like to know about the genitourinary urinary problems and how one can prevent all these problems at that particular age. Sita Lakshmi, madam.
Sita, please unmute. Sita,
Am I audible?
Yeah. We can hear you, ma'am.
Good evening. I thank Dr. Mala and her team for giving me this opportunity. How can one prevent urinary incontinence? It cannot be prevented, but it can be minimized, and early diagnosis and treatment can lead to the improvement in quality of the life. Of course, the pelvic floor exercise should be started in adolescent age group. We are thinking that the Kegel exercise should be done only in the perimenopausal and menopause. That is not true. So the pelvic floor muscle training should be started. We should educate the adolescent girls to start doing the exercise right from their age, and it should be continued through the reproductive life, perimenopausal and menopausal life. So by doing this, the urinary incontinence can be prevented to some extent, and those who are having a symptoms of manifestation of stress urinary incontinence can be minimized. So by doing a good pelvic floor muscle training starting from the adolescent, maintaining through all the phases of life, can minimize or prevent the urinary incontinence. 50-year-old complaining of frequent urination in the night. How will you manage? So first, the diabetes should be excluded because of frequent urination in the night. And sometimes other cardiac problems, non-urinary problems like cardiac diseases, renal problems, all the systemic diseases have to be excluded. After excluding the systemic diseases, the local causes like urge urinary incontinence, urinary tract infection is very common, especially the recurrent UTI and chronic UTI is more common in the menopausal age group because in post-menopausal genitourinary syndrome, nowadays the term is, the recent terminology is post-menopausal genitourinary syndrome. Both symptoms are always coinciding with each other. So due to the deficiency of the estrogen, the epithelium in the urinary tract and the vulva get exposed, and because of that, the patients will have a constant burning sensation in the vulva, and because of the atopic epithelium of the urinary tract, the patient is more prone to get urinary tract infection due to the deficiency of the estrogen. So we have to exclude diabetes, other systemic diseases like cardiac and renal diseases, and other commonest cause for frequent urination in the night is the chronic and recurrent urinary tract infection, which should be excluded by doing the urine routine analysis and culture and sensitivity. Of course, other causes like stone in the bladder, or calculi in the kidney, all have to be excluded before treating the complicated or uncomplicated cystitis. Is Kegel exercise really effective? Yes, it is really effective in some cases, really effective in mild cases. It will prevent the progression of the urinary incontinence, and already manifested cases, it can minimize the severity of the urinary incontinence. So Kegel exercise is very important. And the next question I have forgot.
Non-invasive therapy, madam.
Yes, non-invasive therapy for the management of urinary incontinence. Nowadays, the laser therapy is available. It can be used to some extent along with pelvic floor muscle training. It can reduce the severity of the stress urinary incontinence. Why do women really develop osteoporosis? This is for
Madam, this is not for you. Oh, sorry. That's it, madam. I think your questions you have completed.
Okay.
Yeah. Thank you so much, madam. Thank you so much. So this is, thank you so much, madam. So we move on to the next topic. So that would be on the bone health, for which I would request Dr. Sendil Kamalashekaran sir to take this particular question. And so when is that women really develop osteoporosis? Is any way by which we can prevent it? And what are the methods of detection and prevention? And what is the lifestyle modification that you could do to prevent it? And are there any latest drugs in this treatment? So can you please take this, sir?
Yeah, good evening, Dr. Mala, and thanks to Chennai Osteomenopause Society for giving me this opportunity. I hope I'm audible.
Yes, yes, very well.
Okay, so I'll take the first question. When do women really develop osteoporosis? Is there any way by which we can prevent it? Uh, Menopause in women actually kind of shuts down your hormonal cycle. So you have a reduction in your estrogen production, and as you know, estrogen helps to create a state in which your receptors are actually kind of shut down. So when you have menopause, your estrogen receptors shut down, and you have a situation in which you're actually losing a lot of calcium. So when you're losing your calcium and you lose it in your urine as a urinary calcium, you use you lose it in your sweat and other things. And also if you have a deficiency of vitamin D, then you also have a lack in absorption of the calcium. So that's the reason why you actually develop the osteoporosis. So initially for this, they started off treatment with hormone replacement therapy, but because of the side effects of HRT, like breast cancer and having other problems, they nowadays we don't use HRT as the primary mode of treatment of osteoporosis in the perimenopausal age group. Is there any way by which we can prevent it? Yes, there are many ways by which we can prevent it. First, we have to make sure that the person is actually not taking any kind of medications or anything which are actually inducing it, the secondary causes of osteoporosis. So we actually have to look into that. If patients on medications, those like steroids and the thing, we need to make sure that the patient is not on that, so that can actually, or you need to see why the person is getting the reason for low mineral density, bone mineral density. Exercise is a very good way by which we can actually kind of reduce osteoporosis. So we advise people who are actually in the perimenopausal age group to start exercising, especially apart from walking. We also ask them to do weight training exercises at least 3 to 4 times a week, and that actually builds up your muscle mass and prevents you from getting uh, weak bones. Methods of detection and prevention strategies. Okay, so the methods of detection, actually the gold standard nowadays is doing a DEXA scan. So DEXA scan, as I think one of our talkers had mentioned earlier on, Dr. Muthukumaran, about DEXA, that it's a very easy way of diagnosis. You don't have the patient having any radiation. You just ask them to lie on a scanner, and you get the pass the rays through the body, and we get the amount of fat content, and you also get the bone mineral density. So based on the T scores, by comparing it with the same age group population, we classify them as either osteopenic or osteoporotic. So if they have a T score less -1 and to -2.5, we put them as osteopenic. And if you have any T score above -2.5, we stage them as osteoporotic. And if they have any score of above -2.5 with any vertebral fractures or any other fractures, we call them as severely osteoporotic. So basically, the aim of detection of this problem is to make sure that we can prevent fragility fractures. So if a person who is in the menopausal age group, we have to offer them this test so that we can assess which category they fall in, and we can start them on early treatment to prevent fractures. Because once the as we know, this osteopenia and osteoporosis is very silent, and we will get to know a person having this problem only after they have fallen or fractured a bones. And some of these fractures are very insignificant, and like vertebral fractures may be very insignificant and they may not have too much pain. Or if they've had a fall and they have a very severe fracture, then the pain needs to be addressed. So that's the thing. So prevention strategies. So we have to start people on calcium, vitamin D at the earliest. But to improve their bone density, as per se, nowadays we go in for the more newer medications like monoclonal antibodies. And I think that's the last question. So I think I'll tell about that also. So lifestyle modifications which could prevent it, as I said, exercises. And if you have a person in the elderly age group at home who has had a kind of a fracture or anything like that, we need to make sure that the prevention is there. So basically, if the elderly person is in the house, then to prevent fractures, we have to take all precautions for that. So what by that, I would say that you need to make sure that the lightings in the house or hallway is very good. We need to make sure there's railings around so that they don't fall down. The balance is good. And if they have a poor balance, then that needs to be investigated. And we need to make sure that those kind of things will help to prevent fractures, as that's the main thing which we actually look forward to prevent, so that the patients do not land up in any hospital. The latest drugs in the treatment, as I said earlier on, you were using bisphosphonates, and actually bisphosphonates are still the first line of treatment. The mechanism of action of bisphosphonates are mainly anti-resorptive. So they just kind of act on the osteoclasts and prevent their overactivity, so that the bone stock is maintained. The only medication in the market at the moment, which is anabolic to the bone and giving bone strength, is teriparatide, and this is a daily injection. So this is actually kind of, sometimes patients who are osteoporotic find it difficult to take daily injections, and they're not keen on taking daily injections. However, giving just an anti-resorptive treatment for people with severe osteoporosis does not work. So nowadays, the latest drug which has come out is romosozumab, and the mechanism of action is that it binds to a receptor called sclerostin, and that helps to both act in an anabolic and an anti-resorptive way, and helps to prevent helps to prevent fractures.
Yeah, thank you so much, sir. I think we have quite a lot of information to be gathered from you. So we will have another separate session, sir, to discuss on all of these aspects. We'll have a separately dedicated CME for which we will invite you. We'd like to hear more from you, sir. I think because of want of time, so we will move on to the next question. So thank you so much for all your valuable feedbacks and your inputs. It truly added value to our panel, sir. So I'll get back to you at a later date for a detailed CME on this particular topic. Thank you so much, sir. So
thank you.
Yeah. So we move on to the next topic, like cancer prevention. So Dr. Jayashree Natarajan. So just, I think, madam, we are really running short of time, and I believe the platform people have their time specific duration. So just we will address just one question on this, ma'am. So what do you think, when exactly a woman should get a gynec opinion for prevention of any gynecological or breast malignancies? Kindly address just this one particular question, and then we'll move on to the next faculty.
Yeah, basically, when gynec opinion is not something which you have to go only when you have a problem. Women should understand it's part of her healthcare routine. Then a woman in midlife definitely has to go to a gynecologist or a family physician to know about the breast health and gynec health. And screening for gynec cancers and for breast cancer is mandatory.
Yeah, okay, madam. So we will, madam, hear more from you at a later session, madam. Sorry about this. And then as we have to wind up, I believe. Thank you so much, madam, for your participating in our panel discussion. I will catch up with you at a later date. Hello, Dr. Deepa Tangavani. Again, here she is our very own gynecologist. So now, Deepa, just can you please tell me how do you manage hot flushes with non-hormonal therapy?
Okay.
Just only that, Dr. Deepa.
Okay. Hot flushes. So because of thank you, Mala madam, and thank you CMS for giving me this opportunity. See, hot flushes is the only indications, most common indication where we normally advise hormone replacement therapy. There are few people they don't come into the criteria for hormone replacement. Then we have to go for a non-hormonal therapy. First is the lifestyle modifications where they have to stay in a looser like wearing what are the garments they have to wear, cottony things, looser things, and then the place where they have to give lots of aerated, keep AC in the night. All those things we can tell them. And non-hormonal methods of medical pharmacological non-hormonal, we have starting from venlafaxine, SSRI and SSNRI. We can give like Fludox, we can give Fludac, as well as we can give venlafaxine and gabapentin. These are the most common things we will be thinking about non-hormonal things. Especially if they have a sleep disturbances because of hot flushes, that gabapentin will come into the play. And other things like there is very all that's herbs kind of things. They don't have any evidence to use herbs. So better you use hormone or non-hormonal pharmacological methods. So that's the two advice I can give. I will normally manage, if you ask me the non-hormonal, my first choice will be like Fludac followed by paclitaxel, followed by gabapentin.
So
How
you
long that lasts? It lasts for a longer time. Depends upon some people. Even after 5-6 years later of menopause only, they will be having it, and it goes for 10 years. Some people it will be very short.
Yeah. Okay. Thank you, Deepa. Just one question. What is the hormonal therapy that you will suggest?
Depending upon that, if it is a uterus is there, you have to go for the combined hormonal therapy with estrogen and progesterone. Progesterone, either continuous, or if more than 1 year of postmenopause, you can give continuous, or less than 1 year, you have to give a cyclic. The traditional estrogen and progesterone. Progesterone, if you want, you can go for a micronized progesterone.
Okay, thank you so much. So I think it has been an excellent panel. We had wonderful viewpoints from all our specialists, and I would like to thank all our eminent panelists for participating in this panel discussion. And I know it is really a wide topic, or maybe we can have an isolated CMA on this particular topic at a later date, and I will get back to you to all of you on this particular topic. So thank you so much, and I would like to thank Chennai Menopause Society also for giving me this wonderful opportunity.
Thank you, Dr. Mala, for the wonderful moderation, and thanks all the panelists also for their good inputs. Thanks a lot. And our quiz results, usually we await our quiz results, but Sagiti says she's not able to decipher. There is some technical problem. This is the first time this has happened. So I think today we will not be able to release the quiz results. If I get it later, probably I'll put it up in the. Now, can I call Dr. M.G. Narlakshmi?
Yes, ma'am. I'm available, ma'am. It was a wonderful webinar, and it covered most of the topics surrounding menopause and creating a lot of issues for us as consultants who take care of this women who need our help, and a lot of inputs from all the faculty gave beautiful insights into the and I thank Shanti Madam and Meera Raghavan for having chosen the right persons for the right topic, and it is really a very useful webinar, right from the word go till the end. Maybe it's because of want of time, Mala had to rush through many of her slides during a panel. I see, as Mala said, we will have an individual case discussion, the topic-based discussion sometime in future. Thank you, ma'am. And thank you. I thank Ms. Sahiti of Shield Connect for having given us this flawless platform. As Shanti Madam said, this is the first time we are having a hitch in releasing the quiz winners. And I also thank Mala for putting up a wonderful show in a panel. And I thank the speakers of the first session for having given us a wonderful insight. Thank you, ma'am.
Yeah. Thank you so much, Nana Madam. And
yeah, can we just have a picture? I think only if you presentation is still on. Sakiti, can we have a picture? I would request all the faculty to switch their cameras on. Mala, I would like to.
Yeah.
Dana, Mauna Pramila.
Others have gone, no? Meera is not there.
Yes, ma'am. Previously, I have taken with all of them, ma'am. So now most of them were not there.
Thank you.
Okay, thank you, Shanti ma'am, and thank you, Dana ma'am.
Thank you, Pat. Thank you.
Yeah. So we have come to the end of our webinar. We will see you again in another